Task Force meeting. If everyone go ahead and take a seat. I'd like to welcome everybody here today to the Higher Education Coordinating Board Task Force on Graduate Health Professions. Please remember that this meeting is being broadcast over the internet, and I'd like to sincerely welcome everyone here today. I know that we've got a couple of topics that have a lot of interest. I appreciate folks being here to give their input. I think one of the unique things about this task force setup, it really is designed to provide a forum for good dialogue and communication. So I hope that today in that spirit we'll use this forum in order to do so. So let's go ahead and well, let me just say this. If we have invited folks that are already on the agenda to speak, and if you're here and would like to speak in addition to the people that are on the agenda, please go to the back and fill out one of the speaker cards, and we'll be happy to have you on when we get to the others after the listed folks have spoken, okay? So that way everyone has an opportunity to participate in the process. While I'm thinking about it, as a reminder, the idea is that we're going to hold each group's comments to about 3 minutes. Now, if we need to have additional dialogue, that's fine. But if you'll please try and keep your comments in that time frame at first, it would be greatly appreciated. We have the friendly red card over here when we get 1 minute out to let you know so that you can come up with a summation of your points. All right, well, let's go ahead and jump into the program. And we are going to start with the overview of the staff report on the white paper of Doctor of Nursing Practice. And Senior Program Director Chris Fowler will provide a summary of the development of the Doctor of Nursing Practice DNP programs in Texas. An overview of national accreditation calls for the DNP to serve as the entry into advanced nursing practice, and a presentation of survey responses. Thank you, Chris. And after Chris has spoken, we'll hear from the nursing stakeholders.
Thank you. Again, I'm Chris Fowler from the War Division, representing the division staff who prepared the white paper on the DNP. As you may know, this paper was prepared at the specific request of board members to answer questions about this new degree. Typical of white papers, it is intended to inform the board rather than to offer recommendations on the degree. The report is organized around 4 questions. 2 questions we think are answered fairly directly. What is the Doctor of Nursing Practice, the DNP, and how and why has it proliferated? 2 other questions are supported by data and other research results, but are left for the board's consideration. Does the state need more DNPs? And should the board consider approving programs that represent a BSN to DNP pathway? If the answer is yes to the last question, then that would be a change in the board's position from considering only programs that represent an MSN to DNP pathway. A little bit of background. The DNP is a degree expansion effort. It is an increase in educational requirements and higher degree attainment for entry into advanced nursing practice. And in the last 10 years, we've seen other expansion efforts: the Doctor of Pharmacy, the Doctor of Audiology, the Doctor of Physical Therapy. Degree expansion efforts are often motivated by schools wanting market differentiation in competing for students, professions needing new skills in a changing healthcare environment, a desire for professional parity in an era calling for greater interprofessional collaboration. And sometimes it's just the number of hours in the degree. The state average for a master's degree is 36 hours. The American Association of Colleges of Nursing, or AACN, one of 2 major national organizations representing nursing education, has led the move from the master's degree to the DNP by 2015. If Texas was to fully embrace that policy position, it would mean additional education for approximately 91%, or 1,200 of the state's master's degree graduates each year, and that's 2011 graduation numbers. So what is the DNP? It is a practice-intensive degree versus the PhD in nursing, which is a research-intensive degree. Students are taught to translate research into practice rather than to conduct original research. The degree adds more classroom and clinical practice hours and culminates with a scholarly project rather than a dissertation. It affects the education of 5 specialty areas of graduate nursing education: nurse practitioner, nurse midwife, nurse anesthetist, and clinical nurse specialist. These 4 represent advanced practice registered nurses, or APRNs. I'll give you a scale of that. There are 16,500 licensed APRNs in Texas, of which 11,000, the lion's share, are nurse practitioners. 4,000 are nurse anesthetists, 1,400 are clinical nurse specialists, and 400 are nurse midwives. The DNP also affects nurse administration. It is the 2nd largest specialty program in terms of numbers of master's degree graduates after nurse practitioners. Success in degree expansion efforts is often influenced by the regulatory environment for a profession, and accreditation bodies approve educational programs. And nursing has 2 principal accreditors. One is associated with the AACN, which endorses the DNP as a new entry to practice, and the other is associated with the NLN, or National League for Nursing, which advocates multiple pathways for APRNs. Both bodies will continue to accredit master's degrees, at least for the foreseeable future. Certification bodies verify the knowledge of graduates, usually through a standardized exam, for a specific advanced practice role. The various certification bodies for advanced nursing practice support the move to the DNP, but only the nurse anesthetist group requires new graduates to have the DNP by 2025. Licensure bodies recognize the graduate's credentials to practice in the state. The Board of Nursing does that in Texas, and it abides by national licensing standards. The nurse must have a master's degree or higher, graduate from an accredited program, and be certified as an APRN. The number of DNP programs have increased substantially at the national level. In 2007, the country had 50 programs. The latest numbers show that 193 institutions offer the DNP in 42 states. 35% had the BSN to DNP pathway, 65% had the MSN to D pathway. There were approximately 9,000 enrollees, 1,600 graduates in 2011. In Texas, 12 institutions offer the DNP, or DNAP in this case. 7 are public, 5 are private. 9 offer the MSN DNP or DNAP only. The 12 reported 457 enrollees and 94 graduates in academic year 2012. Does the state need more DNPs programs? Coordinating board staff gauges the need for more programs by looking at access to the degree, student interest, and workforce demand. Physical access to degree programs is not as big an issue as in the past. Obviously, we have distance technology. The vast majority of DNP programs are delivered in a hybrid format or fully online in Texas and the U.S. One interesting thing we learned from our survey was that there were approximately 20 out-of-state institutions enrolling nursing faculty and staff in DNP programs. In some cases, the physical location of the institution is important to accessibility. With that in mind, 8 of the 12 programs reside at institutions located in either the Metroplex or Houston. Student interest. Our survey showed that among schools offering the MSN-DP pathway, applicants increased over the last 5 years, but at a slower rate than admission capacity. In academic year 2012, there were 285 applicants for 240 available positions or seats, and 160 new students enrolled to fill those 240 seats. Staff also reviewed approximately 200 job postings and surveyed 7 major healthcare employers in the Houston-Galveston area to gauge demand for DNP graduates. We found that postings and employers' preferences did not reflect a demand for the DNP. In a few cases, the DNP was a preferred credential. Final question addressed in the paper. Should the board consider a BSNDB pathway eliminating the master's degree? There is a list of advantages and disadvantages in the paper beginning on page 16. However, here are some key points from the staff's point of view. The advantages: approving BSN to DN programs would be consistent with the AACN endorsement and the position of the accreditation and certification bodies regulating nurse anesthetists. It would allow schools to realign the curriculum, provide parity with other schools that Texas nursing programs compete with for national prominence, and with other professions in the workplace. It would provide new skills for graduates to translate research into practice for better health outcomes. The disadvantages: the DNP as the entry to practice exceeds most regulatory requirements. It increases time to degree, costs the student by as much as $21,000, and costs the state and formula funding by as much as $27,000 per student. By eliminating the MSN, the DNP would reduce a pipeline for master's prepared faculty, particularly at community colleges. Master's prepared faculty represent 75% of all faculty teaching in initial licensure programs in Texas. The DNP ignores a body of research that shows the efficacy of master's prepared APRNs. And finally, the longer time to degree and additional hours may discourage some students from entering APRN education and could create or exacerbate a shortage of nurses. This is our overview. Are there any questions?
Thank you very much. Appreciate that. All right, so we've got several groups that have been invited, and we'll have open discussion for others that would like to be put in if you've signed up, and I don't know if we've received any of those. Once again, 3 minutes per group, and so we will begin with programs that have pending proposals or have clearly notified the coordinating board of their interest to develop a Doctor of Nursing practice program. This does not mean that other institutions may not develop such programs in the future. Representatives from Prairie View A&M, the University of Texas Tyler, the University of Texas Health Science Center Houston School of Nursing will begin. So if we could have those folks come on up to the microphones, we'll start the conversation with the Prairie View A&M University. And welcome to each of you. We appreciate your attendance today, and we'll look forward to your comments. And if you'll, the person from Prairie View, well, you're in the hot seat first, so if you'll
thank you.
Tell us who you are and then go ahead and make your comments, please.
Please make sure you turn on your mics,
Thank
which
you.
I didn't do.
You're on.
Thank you. Thank you very much. My name is Betty N. Adams, and I serve as Dean of the College of Nursing at Prairie View A&M University. I have been in that position since year 2000, June 1st. So it is my pleasure to speak on behalf of our university, but certainly to the Committee on Academic and Workforce Success. You do have before you our proposal, which has also been reviewed by your external site visitors most recently. It is our intent to offer a Doctor of Nursing practice, and it will be a postmaster's entry level exclusively to admit family nurse practitioners at this time. We have great support from our community partners, most specifically from the Houston Endowment, of which they have entrusted $3 million to support us in this effort, which will greatly help us as we begin this journey. Prairie View A&M University is in its 136th year. As you know, it is the second oldest state-supported institution in Texas. Nursing was its first academic degree. We will be celebrating our 100th year in the next 6 years. So we are very proud of this accomplishment. Having a offering of a doctor of nursing practice will help us to emulate the success of the college in attracting a multicultural, multi-ethnic group, which is unprecedented in institutions presently offering the DNP in the Gulf Coast in Houston, and also which was most recognized by the site visitors most recently. The evaluation team complimented us on the fact that we have been able to meet a need of having a demographic distribution of nurses that emulate the changes in the nation as well as in Texas, and most specifically as the state addresses closing the gap. So we know we need a diverse workforce, and Prairie View has demonstrated this and will carry that type of change into this doctoral education. The Institute of Medicine report really supports the doctor of nursing practice as well. Nursing education should serve as a platform for continuing lifelong learning, which also can be emphasized through the highest level of educational preparation that we can offer, and certainly in advanced practice, nursing evidence-based. So having the opportunity to establish and educate this distinguished leader of the nursing profession will only help us to be able to do more in this state, but most specifically in the Gulf Coast area and for society. It's bringing that leadership from the bedside to the boardroom and over and beyond. These nurse leaders who are being produced, such as what we will do at Prairie View, will act as full partners with other health professionals and be accountable in their own contributions in delivering high-quality care while working collaboratively with leaders across the state. So again, I thank you, and we look forward to your approval, your recommendation for approval and movement of this proposal to the full board. Thank you.
Great. Thank you very much. Task force members, any questions? All right, we will go on to from Tyler, and that, yes, ma'am.
Good afternoon. Thank you for allowing us to have an opportunity to talk to you. My name is Donna Dickerson. I'm an associate vice president for academic affairs and dean of the graduate school at the University of Texas at Tyler. I'm not here to speak on behalf of our specific proposal. I'm here to speak to the questions that were addressed that you asked the staff to address, and which they did and did a good job of it. I have two things that I really wanted to emphasize as a result of that report. The first thing is that should we have more DNP programs? I actually had forgotten the map that showed how many of these DNP programs were in metropolitan areas. The problem is that in the next several years, we're going to dump 45, and you can argue on the numbers. It'll be somewhere between 35 and 50 million uninsured people into the health insurance system. We are going to have a major health delivery disaster in the making. Add to that a growing population of aging baby boomers, all of us included, and more chronic illnesses from diabetes to cancer. There aren't enough physicians to go around. And I don't care if you build 2 medical schools or 5 medical schools. The research shows that less than 50% of those graduating from medical school will stay in the state. There aren't enough physicians to go around. The ones that will stay in Texas don't want to go into the lower paying family practice area. They want to specialize. They want to live in a large urban area. And they want to work for, in Texas, hospital clinics, or in other states actually work for hospitals. There they have a salary, a guaranteed salary. They don't want to set up their practice in Garrison, Alto, or Sylvan, or any of those other small towns that none of you recognize. So who's going to provide the high-level care for those underserved populations? The master and doctoral prepared nurse practitioner is the answer. The FNPs are doing it now, and they're doing a great job. They're suturing wounds, putting in chest tubes, doing needle biopsies. But study after study has established a clear link between higher levels of nursing education and better patient outcomes. And that's what the DNP provides. It provides better overall health delivery. It is the DNPs, not the MDs, who are going to transform healthcare delivery. They recognize the critical need for highly expert clinicians, even in the most rural and remote areas. They can design studies for their populations, evaluate, and their role is to continuously improve the context with which they deliver their care. So nurses prepared at the doctoral level with a blend of research, clinical, organizational, and leadership skills will significantly impact healthcare outcomes for the better in the state of Texas. Should we have more? Yes. Let me tell you why we need them all over the state. Medical schools, vet schools, pharmacy schools, those students are newly minted post-bacs who can get in a car, move 200 miles, and go to a medical school. These are 30-somethings and 40-somethings who are time-bound, place-bound, and cannot move elsewhere to get their DNP. And that is so important in rural areas. And I'm not talking just about East Texas, but I'm also talking about West Texas. So you end up privileging the metropolitan areas right now by not approving some of these other programs. I know my time is up, but...
Yes, ma'am.
Thank you.
Thank you.
Question.
All right, we have questions, Commissioner?
You made a comment that you cited research that demonstrates that the more highly trained a nurse is, the better the health outcomes. Is that the correct,
yes.
accurate
In
paraphrase?
fact, I believe that's research done by our eminent Dean of Nursing at the University of Texas at Austin. I don't have the citation with me, but...
Because you will recall that our report noted that we are unaware of any research that demonstrates that DNPs yield better health outcomes than nurses trained at the master's level.
And that is not what I found when I did my research.
We would be very eager to look at the research that you cited.
Okay.
Thank you.
I can
Thank you.
find it.
David?
So that is the question. Because if there is an improvement either in cost or efficacy, why would we not then ask all of the MSNs to train to the DNP level?
Well, you're getting into one of the areas, and this is a personal bias of mine. If I had to do it, my ideal faculty member at the baccalaureate level would be an FNP and a DNP in the classroom. The DNP has 1,000 hours of clinical practice. The MSNs who now teach many of our baccalaureate students don't have half of that, even with their own practices and their own experience. So better prepared clinicians in the classroom is going to result in a better prepared RN. And I would do away with the MSN altogether and have the FNP and the DNP. The generic MSN, I do not think is the best solution for either the community colleges or the baccalaureate degree RN programs. I think the best teachers are going to be the FNPs and the DNPs. And I do have information that contrary to what the report said, that there are studies that show that at least 70 to 75% of the people who are in DNP programs or recently graduated would like to combine teaching with their clinical practice, which is what most of our clinical instructors do now.
So are you saying that the DNP requires 1,000 hours of clinical experience?
No, the FNP does.
Okay, so I'm not familiar with the FNP. I understand what it stands for. Is that equal to a DNP?
No. The DNP adds the research on top of that, not the basic research, but the practice research. This is what is often referred to in the literature as a scholarship of the clinical work. And this is the person who can, while our FNPs are really good at taking research and applying it, the evidence-based approach. The DNP is the one who can come in, who's got good research skills, good assessment skills, and can run assessments in their own populations, in their own clinical areas, and come up with the best practices that the FNP and the RNs use. They're better prepared as critical thinkers, as people who understand that their job is more than just one single patient. It is developing clinical practices for that population that they serve.
So you're saying, and this is runs somewhat counter to all of the other nursing deans that I've spoken to about this, is
Well, I'm not a nursing dean, so I may be spouting heresy here.
Okay, well, I want to get you on the record because you've got an opinion, and I appreciate that. So all of these folks we've trained at the master's level that have an APN degree, and they're licensed, and they're master's trained, are you saying that they should go back to school?
No, advanced practice nurses, that's fine. No, they don't have to. I think it would be, we need a certain percentage of those APN trained to go on to the DNP.
What is that percentage?
I don't have the research. I don't have that answer.
Okay.
But right now, it is such a tiny percentage,
right,
that I'm sure we can do a lot better.
Well, here's what I consistently hear from nursing deans. They can't get enough people to go into the PhD programs. They can't get enough people to get a master's in nursing education. And at the same time, we're adding these new programs that look very sexy, very attractive to nurses who want to go into these alternate programs. Aren't we cutting our nose off to spite our face?
You know, frankly, at UT Tyler, that's not our experience. We have a brand new PhD in nursing, and I don't know how many people Dr. Barbara Haas, who began that program, but we've got large numbers of students in our PhD program. And our MSN program, just the MSN, is very large. Our FNP, our Masters of Nurse Practice, we've got 120 or 130 students in that program. We don't have a problem getting students. But we have a lot of nurse practitioners out there who want more. They want to be able to give more to their clinical setting. They want more expertise to be able to improve the health care of their clients and in their clinical setting.
And to them, the online DNP, MSN to DNP is not available to them?
The MSN to DNP online?
The Master's Nurse Practitioner, the ANP, could not go to one of these institutions that's already offering it and get their DNP online?
I don't know the delivery mode for the DNPs here in Texas.
We've got a couple other nursing deans that probably talk about that, but I thought that was the whole advantage, is it was an online course of instruction where they could actually take it while they're continuing to practice in their community and improve their education.
Yeah.
And I guess I'm looking at staff over here. McGregor, is that my understanding that it's largely an online 1 year of instruction, and then it's 500 hours of clinical?
That's the FNP, not the DNP.
There are a couple of online, I think 3 online DNP programs in Texas that are being offered in Texas, as well as several, I think a couple dozen at least, that are being offered externally. Is that right, Chris?
I don't want to take up everybody's time here, but I do want to point out, you mentioned the 30 to 50 million added healthcare customers that will be seen in the environment, well, starting now or yesterday. I want to ask you and all of you here that if you feel like if we continue status quo, are we ever going to be able to meet those needs?
No.
Is the state of Texas prepared for the onslaught right now to take care
Everything
of the needs?
I've read is that no, they're not. Otherwise, we wouldn't be starting 2 new medical schools. And that's certainly not going to, they're going to, admit 10 or 15 students a year? I mean, it'll be ages before they graduate enough MDs to be able to get the job done. So they're not solving the problem. Whereas we can produce FNPs and DNPs who can run clinics and take care of most of that burden.
What do you see as the cost versus training an MD versus training a DNP?
Well, DNP is a lot less expensive. An MD, remember that an MD is coming right out of a baccalaureate program. If they've had some biology and biochemistry, that's all they're coming in with. That student that goes into an FNP or a DNP is already got, if they're going in the DNP, they've already got 1,000 hours of clinical experience through their degree in addition to their years of clinical experience.
Thank you so
through
much.
their job.
We're ready for the
Thank
next
you.
speaker.
From the University of Texas Health Science Center, Houston, the School of Nursing. Please.
Good afternoon. My name is Dr. Joanne Hickey, and I'm representing UT Houston. Thank you for the opportunity to comment on the DNP programs, and specifically the DNP programs in Texas. I'm the coordinator of the program, and this is the first program in Texas which was started in 2006. So we have a little bit that we can share with you on the qualitative data from our experience over the last several years. I've read the Doctor of Nursing Practice degree white paper and would like to comment and really add to the section that refers to added value to healthcare. It's on page 19 and 20. And when I think of this, I think of it more as what's the return on investment for the state of Texas as a response to the DNP program. Today, almost all of our graduates practice across Texas. They're from the Panhandle, they're down in Brownsville, they're every place in between. They're in rural areas, they're taking care of the underserved, under-resourced patients. Was noted that 31% of the DNPs teach either part-time or full-time in programs in nursing. And I think that's part of the picture, but not the whole picture. At least our experience has been that all of our graduates have adjunct appointments and are precepting students and are doing presentations and so forth, even though they may not be officially classified as employed in a full-time or part-time position. Today, we are requesting removal of the contingency of our DNP program to allow us to offer the BSN to DNP for the nurse anesthesia program, and this will be discussed further tomorrow. Some of our graduates have stayed in their same jobs, and others have moved on, but all of them, regardless if they've stayed in the same job or taken new jobs, have increased their responsibilities. It's a new role of responsibilities. And these responsibilities and roles are influencing outcomes not only for just individual patients, but for populations of patients. It's making a difference for diabetic patients, heart failure patients, and so forth. And they're changing treatment protocols, and they're creating new models of care and practice. Examples, other than what I just mentioned, we have one that has been working on sepsis, early identification of sepsis. A number of them are working in implementation in medical homes. DNP graduates are leaders. They're expert clinicians, and they know how to identify problems and also how to work in organizations. They understand systems and organizations, that this is where the decisions are made on how health care is delivered. We talk about the translation role of the DNPs, and that sounds simple. It just sounds like a one focus. But in order to translate, they need to recognize a clinical problem or system problem that affects quality and safety. They need to be able to review the literature, identify what's important, and also the strength of the evidence. Is it just hearsay, or is it randomized controlled trials, or whatever? What's the strength of that evidence? They're innovators in matching evidence to particular problems being addressed. They translate what is known about a problem within the context of the practice setting. You just can't pick things up that work in one place and put them into another. The whole contextual piece is very important. The translational work that DNPs do as leaders, it's high-level quality improvement work, and they're very skilled in using data, how to collect data, and how to measure data. DNP graduates are involved in community engagement work and creating new models for improving health care of communities. A couple examples. Dr. Christine Blanco, one of our graduates, is working with the Promodoras in El Paso to increase breastfeeding. Dr. Nancy Sandusky, she's a psych mental health nurse practitioner. She works with the homeless mentally ill patients in San Antonio. And I could go on with other examples. Our DNP graduates also influence national health policy. Examples, Dr. Lori Hull-Gramish has been appointed director of the multi-million-dollar CMS grant in Houston. This is one of 5 grants that have been awarded throughout the country. She will be among 4 other nurse leaders who will be influencing health policy decisions of the CMS. Dr. Iris Sanchez works down in the Brownsville area and also works at the state and national level with diabetic organizations to change reimbursement that will support new models of patient care. So the value added to health care and the return on investment of Texas for the support of the DNP education has been significant and will undoubtedly continue. In short, the DNP graduates are leaders in reshaping health care in the state of Texas from cost-effective, safe, high-quality care outcomes, and their influence is also extended beyond the state level to the national level. Thank you.
Thank you. Any questions, Dave?
You're speaking primarily on the nurse anesthetist program. Is that true?
No, what I spoke about was our DNP program, the graduates that have come forth from our program. The proposal on the table, which I believe is going to be discussed tomorrow, has to do with the BSN to DNP. So I just added that in to help to provide a contextual piece for my discussion.
So you have another expert here in the room that will be here tomorrow to talk about that specifically?
Yes.
Okay. So all of your other programs are going to continue to be a master's to DNP type of program. Is that correct? And the real question is as we asked the other lady, are there any studies indicating that the quality of care is enhanced, the patient outcomes are better, the costs are lower by training at the DNP level as opposed to the master's level?
The programs, our program began in 2006, and we were one of the first in the nation. There hasn't been enough time to really be able to do good research studies to identify outcomes. What I'm sharing with you is the anecdotal kind of qualitative descriptions that I can give you about the impact of our graduates and what they're doing for the state of Texas.
Are you familiar with what they did in Ohio with limiting the number of graduates and capping that funding for a period of time until that could be studied?
No, I am not.
Yeah. So the question is if it is going to be a considerable additional cost to the state, obviously cost of time and money to the individual who's going to have to borrow to pay for that, and we really haven't demonstrated the efficacy. How many years do you think it would take before we'd be able to know a comparison of the master's level trained nurse practitioner versus the doctoral level trained, and put a side-by-side comparison? Do we say there is value and it's worth this amount? How many years would it take to study that?
I'd like to answer it this way. There was a meeting held in August of leaders throughout the country, and what was being presented was descriptive work about programs. There has not been the correlations of outcome work yet. How long it's going to take, I don't know. I would hope within the next 5 years. That's my personal guess.
As far as you know, the accrediting bodies are not planning on making the entry level a DNP, though, in these other fields, like they did with nurse anesthetists.
The American Association of Colleges of Nursing, which accredits the other programs, including the DNP program, have said that they would like to move in that direction. But it's not happening all over the place. And my understanding is that they don't see this as every single nurse needs to be at that level at this time. Perhaps in the future, as knowledge changes and there's more demand for that level of practice, that may change.
Thank you.
Go ahead.
Do you see a fast track available that would allow someone with a BSN to opt out after a certain number of hours? If they feel like they couldn't finish, then they would have their APN without necessarily duplicating any of the hours or anything if they came back a year later and wanted to do the DNP. Is that what your program offers, or?
What we do a postmasters. All of our
All
graduates,
of yours are postmasters.
all of our students have master's degrees. So they come in as nurse practitioners,
Sure.
clinical nurse specialists.
But in the future, if the national standards change to the point where more people are wanting just straight BSN to DNP, would there be an option for that?
Oh, I believe so.
Just to opt out after, 36 hours, and then you would be awarded your master's, but you would, if you stayed on track, you could still do the DNP in, 36 months?
I guess I'm not understanding.
Oh, that's the anesthesia program. I'm getting it mixed up now.
Okay.
I do feel like you've seen with your graduates. Recently, I know my hospital system has employed, I believe, 6 new DNP positions that were put in place, and the reasoning was of the dollars on the table. And with the Affordable Health Care Act, so much of the dollars require a grant written for it. And those applications are now being done by DNPs, not by PhDs, not by MDs, and not by just me, a nurse. But these DNPs were hired strictly to bring down those dollars, and they are putting them out. And I've been very impressed with their ability to write grants, and every dollar we get from the Affordable Care Act has to have a plan, has to be proven. We have to measure the outcomes. We have to do all of these things, sing and dance to get those dollars. And this is the profession that's going to get it for us. So I appreciate it.
Any other questions for our group? All right, thank you all so much for taking the time to be here. We appreciate your input. So moving along, our next group includes representatives from the Texas Board of Nursing, the Texas Organization of Baccalaureate and Graduate Nursing, and the Texas Organization of Associate Degree Nursing Education. If each of y'all would come on up and take a seat, we will work through y'all. And we'll start with the Texas Board of Nursing. Thank you.
Good afternoon. My name is Jolene Zeich. I am a staff member of the Texas Board of Nursing. I'm a nurse consultant. I am a registered nurse and also a women's health nurse practitioner by background. I want to begin by clarifying that the board does not have a position on any of the proposals that are before you. I'm here as a resource to you. The board has not taken a position on the Doctor of Nursing practice degree, but I would also point out that the board has not discussed the issue of going from a baccalaureate degree to doctoral education, regardless of whether that's a baccalaureate degree to a Doctor of Nursing practice degree or a baccalaureate degree to a PhD. And I'm aware of BSN to PhD programs that are here in Texas. The board is very supportive of nurses furthering their education and always has been. The Doctor of Nursing practice is not exclusively an advanced practice degree. It is also offered to, as you heard earlier, nurse administrators. We're aware that there are programs in other states that also offer degrees in policy, nursing education, in DNP programs. So I need to point out that not every nurse who has completed a DNP program is an advanced practice registered nurse, and I want to be very clear on that. The board is also very much aware of the Institute of Medicine report and the call for higher education and more nurses to be doctorally prepared. Specifically, I'd like to address the advanced practice registered nurses because I understand that's where many of your questions are. And we recognize that there's been an evolution in advanced practice nursing education over the years. When we first started advanced practice nursing, the board began regulating advanced practice nurses in 1980, but they've been around a whole lot longer than that. We started with educating advanced practice nurses as a post-RN licensure certificate. So we had associate and diploma prepared nurses who completed a certificate and practiced at an advanced level. That's since moved on to the master's level in the late 90s, early 2000s, and now we're beginning to see that evolution continue to the doctoral level as we've seen with the nurse anesthetists. We expect that this may continue with the other roles. We don't know when. And I'm not going to try and guess as to when that might occur. The board is very supportive of uniform licensure requirements for nurses at all levels of licensure, for LVNs, for RNs, and for advanced practice registered nurses. We've been a member of the RN and LVN licensure compact since 2000. We were one of the first 5 states to implement that. And it encouraged us to have standard requirements for education and for licensure across the United States. And it makes it easier for nurses to move from one state to another for practice. We anticipate being part of the APRN compact in the future, and in fact participated in the development of the consensus model for APRN regulation. Again, the consensus model also focuses on standardization across education roles. And I see my time is up.
Okay.
Happy to answer any questions.
David?
Yeah, thank you for being here, being a resource.
Sure.
The question I would have is, do you have any information as to how many as a percentage of nurses, we say that's the body out there, how many need to be trained at the various levels in order to have an adequate workforce? Are there any studies? Is there something internal within the Board of Nursing? Is there a benchmark out there where we can say these are the ADN needs, these are the RN BSRN needs, this is the master's level trained needs?
There is not within the Board of Nursing. The Texas Center for Nursing Workforce Studies does collect data, various education levels, and workforce information. I don't have that from the Board of Nursing. I'm sorry.
Okay. And your nursing board, on your nursing board, those people are, I guess, appointed by the governor?
Yes, sir.
And how many of those people are PhD nursing educators?
Give me a minute to think. We do have 3 nursing education representatives. Our baccalaureate degree level is doctorally prepared, a doctorally prepared nurse.
And do you have any that have a DNP?
Not on the board. We have a staff member who has a DNP.
How about the advanced practice RNs, the APRN? Are there any of those members of your board?
We have 1 APRN member of our board, and my understanding is that she's master's prepared.
So the conundrum that we are coming up against is a National Nursing Trade Association has made a unilateral decision that's going to force Texas, since they're the only certifying body, into having to educate our nurse anesthetists at a doctoral level only. Is there a mechanism within the state regulatory agency to allow a person to train at the master's level and still gain a license even though they're not certified by a national certifying body?
At this point, there is not. The board's rules require both national certification and completion of a nationally accredited program. The board has required that since 1996 and enforced it since 1996. The reason being, we want all of our graduates, first of all, it enhances their mobility to be able to go to other states. It also ensures that we don't have substandard programs here in Texas. We wouldn't want our Texas graduates to be educated. I know your proposal that you're looking at tomorrow is nurse anesthesia, so let's use that as an example. If we had a state program that didn't meet the national standards, we could, say, have a program that prepared a nurse anesthetist to provide anesthesia for all types of cases except maybe obstetrics. That would not be consistent with the national standard. They would not be eligible for licensure in any other state. And they would not have passed the national exam because they're missing a huge piece of what is the minimum standard for that education.
And you can see how we as a coordinating board would not necessarily care if they couldn't be licensed in another state. We're trying to staff nurses for Texas. And our mission is Texas first. So the real question is that is a board rule. It is not a statute.
It is not in the statute. It is consistent with national licensure standards.
Right. And I'm not trying to debate the point. My only point is someone has changed the standard unilaterally at the national level without demonstrating, at least to our white paper, that there's any improvement in outcomes or efficacy or costs. And so they're challenging the state to have additional costs. The student is having to go through additional time to train, and no one's shown that any therapeutic benefit to the patients or to the state. And so I guess that would be my question. Thank you.
Not sure I understand the question.
It's not.
Okay.
Sounded more like a
sure.
statement.
Yeah.
That's great. Any others? Okay, moving along. The representative from the Texas Organization of Baccalaureate in Graduate Nursing Education, please. Microphone, please. Thank you.
My name is Patricia Stark, and I'm from the University of Texas Health Science Center at Houston, speaking to you to represent the Organization of Baccalaureate and Higher Degree Education. Our president is Carolina Huerta from UT Pan American, and she asked me to represent her today. I would also like to clarify some points in the white paper, and then if you have some specific questions about UT Houston and the anesthesia, I'd be glad to answer some of that as well. But I wanted to make certain points about the white paper. One is the implication that if we were to move in this direction, it would jeopardize the pipeline of master's prepared faculty, especially for community colleges. This is completely unfounded because we have master's programs in many roles for nursing. We're only talking about the advanced practice role moving to DNP. So we do not have nurse anesthetists who would teach in a community college. Rarely would a nurse practitioner want to teach in a community college. They can make too much money in practice to seek teaching careers. We have plenty of master's students in other roles that are eligible, and these programs will continue as they are. We currently have 584 master's prepared students in education in Texas, so we have an adequate pipeline. The other point is with saying that 75% of our entry-level faculty are master's prepared. That is not our desired number. That is what we are faced with, because only less than 1/2% of nurses in Texas have a doctorate. So naturally, we don't put our ads out, doctorate required. We put our ads out, master's required, doctorate preferred.
Say that statistic one more time.
1/2 of 1%.
Okay, thank you.
Not even 1% of the nurses in Texas have a doctoral degree. I also wanted to speak to the research issue. Tomorrow you will hear from 2 physicians, one from MD Anderson and one who has been a health policy fellow in Washington, who is also a neurosurgeon, who will talk about their personal experience with the DNPs and a project we did in Houston which definitely saved money and got better patient outcomes. So you will hear more about that tomorrow. I would also say that the research that has been done about DNP students and by DNP students has focused on the improvement they have made in patient care and on patient safety and on producing new protocols. They have not spent their time saying, am I better than the masters prepared? So we're not doing those studies. We don't encourage our students to do those studies. Your question about is there any existing benchmarks, the Institute of Medicine has said that we should have 80% baccalaureate, 20% associate degree, and the state of Texas and around the nation are working for that percentage. So that's the benchmark that we have out there right now. We have a long way to go in meeting that. I have copies of the Texas roadmap that the Association of Baccalaureate and Graduate Nurse Educators produced, and I will tell you that the purpose of us producing this roadmap is that we felt it was important for us to have a plan for the state and not just programs crop up here and there, but that we have a statewide plan and that we try to help each other and collaborate instead of duplicating. So we did prepare a plan. It has 3 goals. First goal is that the patient care needs of our Texas citizens will be met with an adequate number of both primary and specialty caregivers. Second was that we could take the lead in preparing these caregivers. And third, that we would have a cadre of doctorally prepared APRNs to serve as faculty as well as practitioners. There are a number of background factors that I won't go into with the time limit already up, but the reasons why we did this, but we ended up saying there are 2 models that we could do this. We could do it with the model of BSN to DNP, which we feel is the most efficient, is the most cost-effective if we have to end up with the DNP. And the second model is the BSN to MSN to DNP. And that is the model that we are using now. We have worked out a very effective program in Houston, which is the oldest DNP in the state, where our students, we have a program funded by 3 foundations that pay all the tuition and fees for the students to go through and get their family nurse practitioner. And we give them a stipend so that they can decrease their workload and take more schoolwork. And then when they finish, we immediately have them go on for the DNP, and all their tuition and fees are paid. So we have worked out a successful model to do this BSN to MSN to DNP. We have not been able to work out that curriculum plan for the anesthesia, as I'll explain to you tomorrow. And our biggest concern there is our students are showing a preference for the BSN to DNP, and our enrollment has dropped significantly since we don't have that option available for them. But the organization, Baccalaureate Graduate Nursing Education, did make the decision that if there are any new programs that are started in the state, let's don't start the master's and then later have to convert it to the DNP. If new programs are started, let's go ahead and start them as BSN to DNP programs. And that all the other programs in the state should be thinking long term of how they're going to transition to the national preference. Thank you.
Thank you. Questions, David?
Dean Stark, did I misunderstand you? Did you say that the workforce is 80%, the ideal workforce is 80% bachelor's and 20% ADN?
That's correct. That's from the Future of Nursing study done by the Institute of Medicine and the Robert Wood Johnson Foundation.
Well, in Beaumont, that's 100%. Where do you put all the PhDs and masters trained?
No, I'm saying of the entry-level nurses. Of the entry-level nurses,
Okay.
we should be producing 80% baccalaureate, 20% associate.
And then as a percentage of the total nursing workforce, how many should be PhDs?
I have not seen any organization that has put a percentage to that.
Okay.
But with, half of 1%, I guess nobody has thought to say we need 10%. That would be a big goal. But that same report did say we need to double the number of doctorates. So that would give us 1%.
But we're safe to say that we probably need nurses of all stripes.
Absolutely.
More.
Absolutely.
Okay.
Absolutely.
So in your program where you go from the master's nurse practitioner to the DNP, is that primarily an online course?
No. No, our program is a hybrid, and so for what we do, particularly with the doctoral program, is we hold classes 2 days a month. So the students come to the campus every Thursday and Friday of every month for the semester, which is about 4 times a semester, and the rest of it is online. Therefore, we've been able to attract people from around the state who fly in for class 2 days and then fly back. And this is how we have done it with 4 classes, and the model is working well.
So in your model, the nurse who's practicing nursing in Deep East Texas behind the Pine Curtain would come to your location once a quarter for a 3-day experience.
They would come 4 times a semester, which is about once a month, yes.
Once a month, okay. And your students are not saying that that's too much travel, it's
No.
too expensive, it's too difficult?
No, many of them have got their employers' blessing and financing to help them do this because they need them back in the agency with that education.
So the fact that we have our programs concentrated in Houston and the Metroplex and I think in San Antonio is not necessarily that great a burden for nurses around those areas to travel 100, 150 miles to have that experience once a month.
Well, we started our program as the only one in the state. We felt an obligation to specifically try to choose people from around the state, not just we could fill our class with the people in our areas, but we deliberately wanted to seed the whole state with leaders who could then one day perhaps be faculty in programs near their own home area.
Could you expand your enrollment?
If we have money to expand faculty, yes.
Okay.
I think every school would say that.
But starting a new program versus doubling the size of your program would certainly be more economical to double the size of your program. You wouldn't have to have an equal number of faculty to starting a brand new program, would you?
I see where you're going, and I would prefer not to get to answer that question. I really think,
You can imagine how I'm really compelled to get an answer out of you.
Right. With a half of 1% of nurses having doctorates, I don't think we can have too many programs. So I'm supportive of people in all areas of the state who feel that they've got the faculty resources and other things that it takes to mount a good program.
I don't think you're going to get mugged in the parking lot for that one. Last question. That 3-page letter you had, I think we had a conversation a couple weeks ago. There's a statement in there that when a nurse anesthetist gives someone an anesthetic, that's the practice of nursing, but when an anesthesiologist does it, it's a practice of medicine. And I don't know that I can understand how that's possible because if you're putting somebody to sleep as in anesthesia, that's the practice of medicine, isn't it?
What letter was that?
I think you had forwarded a letter from that Janelle had sent me.
Oh, it's from wasn't it the neurosurgeon?
No.
No, from the
3-page
veteran.
letter from an interest group, had a whole number of people that were.
Oh, Texas team.
Texas team.
Texas team.
There you
Okay.
go. Yeah.
I can. My anesthesia director can answer the question about your specific question. But Texas team is a part of that Robert Wood Johnson Institute of Medicine national study that was done. They made recommendations, and then they set up regions to help carry out those recommendations. So Texas team is the name of the regional group in Texas that is promoting those recommendations. But Kristen,
Yes, you probably.
Where's Kristen? Can you come up and you right here? Answer that question.
Good afternoon. Kristen Sternzeit, Nurse Anesthesia Director at UT Houston. To answer the question, the reason why it's practice of nursing is because we have a nursing degree and we're credentialed as nurses. We're not credentialed as medical providers or medical doctors.
Okay, thank you.
You're welcome.
Anything else?
Well, I had a question. I had one DNP call me after he read the report. He felt the costs that were cited in the paper were the extremes. Did you have any thoughts about the costs that were cited versus the savings, or I just would appreciate your thoughts about that.
We did have some concerns about those costs, and we weren't sure how they were derived. We had someone UT System who was looking at that, and I believe they communicated with Chris Fowler, and I think Chris stands by her numbers. Is that what you're saying?
Our finance group felt that the methodology was accurate with the information.
We do know that the private institutions are double and sometimes triple what the state cost is, and we are concerned because students are voting with their feet. They are saying, this is what I want because I realize this is the future. And students are opting to go to wherever they can go to get that program and paying the huge tuition differences. So this is a concern for us as well.
And one other thing, as the state looks at all the programs, is there any employment problem with these graduates?
None at all. No
Do you
problem.
have hospitals or is the industry, the environment saying, wouldn't it be great if you doubled your graduates? Or what is your feedback from hospital systems or education opportunities? What is your feedback?
Feedback we get is because the medical residents have been limited to the number of hours they can work in hospitals, that hospitals are very interested in hiring these highly skilled nurses because the hospitals, as you well know, are not going to get paid if certain things happen, infections and falls and readmissions, and they know that you need a highly clinically skilled person to help keep those outcome measures what they need to be. So intensive care units and other places in hospitals have been very, very interested in these graduates.
Thank you.
Thank you.
Great. Next, we have a speaker from the Texas Organization of Associate Degree Nursing Education.
Good afternoon. I want to thank y'all for giving Associate Degree Nursing an opportunity to have some input on this issue. My name is Debbie Yancey, and I'm president of the Organization of Associate Degree Nursing, and I'm also program director of Wharton County Junior Associate Degree Nursing Program. And
I'm Cheryl Livingood. I'm president-elect of TOADN, and I'm program director for the Associate Degree Nursing Program at Weatherford College.
Okay, we really want everyone to realize that we do see the need to develop alternate educational pathways for our nurses to obtain higher education and to support the development mainly that was discussed in the IOM report of doing a seamless transition for nurses to continue their education. So start out and be able to, increase that education level without duplication of courses. So we definitely approve of that. We have reviewed the roadmap that has been put out regarding the DNP practice, and they call it the Advanced Practice Registered Nurse Education. It's their roadmap. For Texas Organization of Associate Degree Nursing, we're really concerned about the goal number 3. And that goal number 3 states that Texas will prepare the cadre of doctoral prepared APRNs to serve as faculty as well as practitioners. Our primary concern, because as Dr. Stark said, the option that they would like to go is BSN to DNP. And we definitely see that as eliminating the master's prepared level of APRNs. And if we do that, we're going to damage already the fragile pipeline that we have of available candidates for faculty positions in the associate degree nursing programs. Currently, on the Board of Nursing web, their website, you can find that there are 66 approved associate degree nursing programs listed in Texas. We've conducted a survey of those programs and found that there is currently 36 of those programs, which in turn is 54.5%. Those programs have posted available positions as of this month, meaning they need a master's prepared minimum nurse for to educate their students. So of those 36 programs, 50% of them have actually multiple positions posted. The salaries listed are consistent in a consistent range, so we cannot go down the road that it's salary that is keeping the positions where they're not, can't be filled. It does purely, show that there's not enough available candidates now for faculty positions in the associate degree. So reducing a master's prepared level of APRN will only exacerbate this problem. And further survey shows that our current positions that are filled, faculty positions, finds that we are totally in agreement with the THECB white paper in that there's only 4% of DNP prepared individuals in faculty positions at the ADN level. I see that as 96% of your DNP practicing individuals will not be at a community college. That is your associate degree nurse who does do a lot to the health care of Texas. Conversely, for us, if we have to hire more DNP prepared, it also weakens the number of faculty positions that we would be budgeted, because doctoral salaries are like $10,000 more. So we see that as just definitely decreasing the ability for us to even produce more nurses at an associate degree level. Cheryl?
We also wanted to address the fact that the aging of our current faculty in all of our programs indicates that over the next 8 years or so, the retirement of current faculty is going to continue to occur in staggering proportions. I know I personally would like to get a chance to retire if somebody would be here to replace me. While Toden would need to survey all of our existing programs to obtain exact statistics, we can use our 2 programs as examples. Over the next 8 years in my program, we will experience a 54% turnover of faculty to retirement unless we just plain remain in our position beyond retirement age. Wharton County will experience a 50% turnover. When you combine that with the already aforementioned 54% rate among the associate degree programs of current faculty positions, that can combine to produce a staggering picture of the problem that we will have. One of the side effects of that would be that if we have this faculty shortage that could reach epidemic proportions, it could result in having to undo the work that we all have been carefully doing and crafting over the last 5 years to increase available nursing student slots. We've all been growing our programs, and it will, if we do not have the faculty, we will be taking backward steps. That backward step at a time when retirement age is also going to significantly reduce the number of practicing RNs in clinical practice is going to be, could be catastrophic. Additionally, it's that we have the additional concern that the deletion of the master's prepared level for individuals seeking the DNP degree removes the safety net for our students. Right now, it is that if a person had a BSN to DNP degree, I suppose it would be that those programs would develop some kind of a step-back option and opt out if an individual that's enrolled is unable to complete the program due to life issues. They would be able to opt out and at least obtain their master's degree and still then see a reward for their effort. However, if master's prepared level is phased out, then there's not going to be that safety level, a safety net, and all of their hard work could go down the drain. And that would be very discouraging to our graduates. We currently work very hard at associate degree level to encourage all of our graduates to not only seek the BSN, but to think beyond that and to continue to think masters, et cetera. I also would like to address, in deference to our colleague, Dean Stark, who made the statement that advanced practice RNs, typically don't fill positions in faculty as faculty members in associate degree programs. At least in my case, in my program, that's not the case. Almost 50%. In fact, a little over 50% of my current faculty members are advanced practice nurses. I have six of my 11 full-time faculty are advanced practice nurses. 5 of them have master's prepared. I did just hire one DNP. I'll hope she sticks around. So I'll turn it back over.
Yes, and almost 40% of my faculty are nurse practitioners that work occasionally on a weekend or whatever in practice, but so that for us that's pretty significant. So in summary, basically we just want to make sure that we get our point across that we are not here to discourage the growth of DNP practice. We are just basically making a stand that we cannot support phasing out a master's level for them going on for the DNP. Thank you very much for your time. Does anybody have any questions?
Questions, David?
So, and this may not apply to your instance, but the concern is if the national certifying body pulls the plug on a master's trained nurse, where do we go to get them certified if you and I agree that that nurse is quite capable of performing in their traditional function and that nurse is not desirous of moving on to the DNP? Is there an alternate certification body in this state, in this country, or is there just the one?
It's just the one that I'm aware of, and I guess the most frightening thing is all we have is how much health care needs to be, that nursing is the answer to improve our health care, but we're already looking at getting rid of a complete level of of education preparation. I just don't see it being a real good move for health care, not just in Texas.
And that is my personal concern, and I've expressed that. Instead of making it more cost effective, we make it more costly to enter the field. And instead of plussing people up to play at a much higher level, we need as many as we can at the lowest level do as much as they can to free up those of us that may have trained at a higher level. And it would seem to me that the national certifying organization is going to cost the state and our future nurses an awful lot without a whole lot to show for it.
Well, that also takes up the issue that I don't want to, that we don't have time to go in for, but in Texas, we have a lot of rural areas, and I know that many of you asked questions earlier about what do the practice side want in nurses. Well, I live in a small town of 3,000 people. There is not a master's prepared person in our community hospital. Our highest education level is a BSN, and yet we save a lot of lives in that little small hospital.
Do you have nurse practitioners in your community?
We have, according to the data that just came out from the Board of Nursing, or either THEBC, we have 7 in Austin County. And I know of only one of those that works at in Belleville.
And at your hospital, who administers anesthesia?
A CRNA.
Who was trained at the master's level?
Yes.
And that community and those surgeons are quite pleased with the quality of care that nurse anesthetist provides?
Yes.
Thank you.
Everything?
Well, I have one question. So So all of the master level positions are not going to be deleted. I mean, we still have a market. MSNs will still be there, right?
Well, yes, we're addressing the roadmap that states that the option was to do BSN to DNP, and we're here to say, please do not just look at that as the option. We need to keep those master's prepared programs out there.
So there are plenty of master prepared programs that are not even in this category. This is advanced practice nurses we're talking about.
But we're stating that probably 40% of those nurse practitioners are our faculty members.
Well, I understand that, but there are options for community colleges to even take the brightest and the best and sponsor them to pay a scholarship for one of them to get their MSN and then come back and teach in your college. I mean, there are lots of opportunities to drive your own pipeline, just like hospitals do with doctors and the government does by giving scholarships to, soldiers who can then go and I work with an orthopod who still is in the Army paying back his medical school loans. There's lots of opportunities to drive your own pipeline. This is not talking about shutting down your opportunities to get faculty, except for you're obviously wanting to have more APNs. Right.
Well, I think to address that, I guess the best way to look at that would be to say that for whatever reason, our pipeline already has a lot of holes in it. When you look at the number of posted available positions that we have and that they're not getting filled, my person that I just hired that was in a position, that person began December 1st, that was a position that I'd had posted since last March. As so many of us have available faculty positions, when we said earlier that we support seamless transition, we would like to come to the table and see more ADN to MSN degree options allowed there with a focus on nursing education so that we can grow some faculty.
Who's the faculty for the MSN programs? You still have to, we still have to drive a pipeline to get doctoral nurses.
And we agree with that.
Oh, we do not disagree with that. We're just making the statement that the options that is being proposed is to do
that's not this. We're not proposing that. We're looking at what the national board has done. We're not proposing that the master levels be done away with.
Okay, that's great, because we're just looking at the roadmap and what the options were stated there, and we just want to make sure our position was heard, that we don't feel that you can do that, because as it's been stated several times, the future, I think we just heard someone make a statement earlier, if I had my way, there would be no master's prepared. There would just be a DNP. I think someone made that today. That is a concern.
For advanced practice. That was her statement.
Okay.
I appreciate it. Thank you.
Thank y'all.
Thank you.
We have two other folks that have asked the opportunity to speak, representative from Texas A&M Corpus Christi and the representative from the Texas Society of Anesthesiologists. Y'all are welcome to come on up, please. And will the representative from A&M Corpus go ahead and start first, please?
Thank you. I'm pleased to represent the group Other. I'd like to thank the task force members and the coordinating board staff for this opportunity to provide some input in this process. I'm Chris Markwood, the Provost and Vice President for Academic Affairs at Texas A&M University Corpus Christi, and I'm here with Dr. Mary Jane Hamilton, our Dean of our College of Nursing and Health Sciences. Texas A&M University Corpus Christi has a very strong nursing program, which has won numerous awards from the coordinating board itself and has received recognition and funding for innovative nursing education at the national level. We produce a fourth largest number of family nurse practitioner graduates at the master's level among our state universities. In the spirit of full disclosure, as some of you and the staff are aware, Texas A&M University Corpus Christi has an interest in offering a DNP. There are two areas that are touched on in the white paper that we would like to comment on. The first is the job market for DNPs and how DNPs can be used to improve health care delivery. And the second are benefits to South Texas if it has the same access to DNP programs that others in the state have. There are needs for DNP graduates. First, advanced nurse practitioners are needed in healthcare settings, and I think others have testified to examples of that today. But second, DNPs are also needed for faculty positions at colleges and universities. I just came from the annual SACS conference in Dallas, and SACS requires that a minimum of 20%, 25% of all nursing instruction in bachelor's degree programs, including nursing degrees, be offered by faculty with terminal degrees. That includes PhDs and DNPs in nursing. And it applies to the total academic curriculum, including the hours that a student takes in two-year colleges that transfer into that bachelor's degree. Third, DNPs are needed to provide healthcare services in areas like South Texas that are chronically short of physicians, where physicians and nurse practitioners can work in teams. Various estimates place Texas in the range of from 42nd to 47th in the nation in primary care physicians per population. Within Texas, at least 6 South Texas counties are identified as health professional shortage areas. Having DNP programs available in South Texas would improve access to advanced nursing education in the region, would improve the quality of existing nursing programs in our colleges and universities, and would help improve healthcare delivery in one of the most underserved areas in the state. There are currently no existing programs or those under consideration south of San Antonio. Having DNP programs in South Texas would give the many South Texas students interested in nursing the same level of access to their desirable graduate nursing program that people in other areas of the state have. It is our experience that many students who want to pursue the DNP are not very mobile. They are working RNs or faculty at South Texas colleges or universities who would find it extremely difficult to travel to existing program locations, even for short periods of time. Distance education from another region of the state is not always the ideal solution, as distance education programs, such as our own online MSN program, serve a large number of students within 100 miles of our own campus and offer clinical nursing programs in networks that are also close to our own geographic location. For a profession that is disproportionately female, without a program within the region, that means a disproportionate access impact on Hispanic women in South Texas. Finally, colleges and universities in South Texas, as in every other location, are desperately trying to hire doctorally prepared nurses to meet accreditation standards and deliver state-of-the-art training and nursing education. Offering a DNP in South Texas would help our college and universities stay competitive and hire more doctorally prepared faculty. It is our experience that it is often difficult to get DNPs from other regions to move to South Texas. Thus, the location of programs within Texas is an important factor in meeting market needs. As you deliberate the future of postmaster's nursing education, we would respectfully ask that you weigh heavily the positive impact expanded DNP opportunities provide for a better prepared and expanded healthcare workforce, leadership for the profession of practicing nurses, employment needs for college and universities, and the opportunities those needs provide to Texas-prepared DNPs, and the location of existing and proposed programs, and the impact that has on service populations. Thank you.
Great. Thank you. Any questions? Great. Thank you. Next, we have the representative from the Texas Society of Anesthesiologists.
Hi. Good afternoon. My name is Catherine Scholl, and I'm a physician whose specialty happens to be anesthesiology. And I apologize ahead of time. I came here from the dentist chair, so if I start to drool or slur my words, I'm not having a stroke. I came to speak about a couple of issues. I practice in the anesthesia care team, which means I practice with the anesthesiologist assistants and CRNAs. But I have an argument with the white paper in that the white paper says that this expansion to the Doctor of Nursing practice or the PhD program would be practice intensive. You can't learn anesthesiology in a classroom. You can't learn it online. And you're probably going to talk about that tomorrow, but I would argue that there are other specialties that you cannot learn online or in a classroom, that you actually need to be out there doing it. And the second is, are we asking this expansion, are we going to train teachers? Are we going to train researchers? Or are we going to be training field workers? Because if we're training field workers for the nurses that will be at, quote, out in the trenches, and some days they are trenches, we're asking Texans and these students to spend extra dollars for not much gain in clinical specialties, in clinical knowledge, because these extra semester hours are online and in a classroom. And I would ask, who's driving this train? Is the requesting body the same as the accrediting body? In the medical world, we have ACGME and the American Board of Medical Specialties to oversee things in separation from the national organizations of the Academy of Orthopedists or the American Society of Anesthesiologists or even the American Board of Anesthesiologists. The third is, having set this precedent in the healthcare field, as the white paper discussed, for the doctor of pharmacy and stuff, what is to prevent another college or university to say, I'm an economics department and I want to get rid of my economics master's program? You've now set that precedent that they can call on this to say that we've done this. And in answer to Dr. Tischer's question of another individual sitting here before, in Texas law, the practice of anesthesiology is the practice of medicine. There's a lot of controversy between CRNAs and anesthesiologists, all doing with the interpretation of an interpretation by then Attorney General John Cornyn. To the best of my knowledge, as past president of the Texas Society of Anesthesiologists, CRNAs are not allowed to practice independently. They must practice in the presence of a physician, whether it be an anesthesiologist or a surgeon. If the surgeon requests that the anesthesia provider be a CRNA, that is when the practice of anesthesiology then becomes the practice of nursing, in my opinion. And that's all I have to say, and I just got the red card.
Well done.
Any questions?
Any questions? Great. Thank y'all.
David, that's...
That's a first. Thank y'all very much. Appreciate each of the others coming and each of the groups that were represented earlier for the conversation. Your input's very valuable and once again greatly appreciated. So to the task force, it says that we have task force consideration time. Okay, handouts.
Are you reporting tomorrow to one of the committees?
Yes.
Okay. Well, this is a draft, and obviously we had some comments today. I think we ought to, in the interest of accuracy, allow staff to receive any other information and look at the draft and determine if it's a final draft, or if they can look at me right now and tell me that nothing's going to change. But there was some mention of some studies out there that exist regarding quality and efficacy with greater training, and that's certainly a question, I think, for us.
Definite interest. We'd like to see if that's available.
And we were not able to find anything that was specific on point, and I think Dr. Stark mentioned that there were not sufficient numbers of DNPs in the workforce doing comparable work to the advanced practice nurses to be able to conduct a study, and perhaps down the road, I can't remember who mentioned, maybe 5 years, there would be the potential to do that. But at this time that there were not those studies out there. And one of the first speakers did mention that she was aware of some studies, and we would certainly welcome any further information to whatever we missed and that kind of thing. So we'll certainly welcome that.
So because we are a task force of the entire board, I would move that we allow staff to continue to work on this document, share it with us, and then present it to the board at its January meeting.
Okay. Makes sense.
Well, I'd like to say I think as a whole, my charge personally for serving on this board has been to look at coursework that trains our workforce for jobs that are there. I think obviously we've determined there are jobs there. Someone has raised the point that this might raise the cost of health care. I think we should not think that anything in health care is going to have its cost raised by a degree. Aetna's going to pay what they're going to pay in the contract. Medicare is going to pay what they pay in the contract. People are going to hire a skilled workforce because they want better outcomes, and outcomes are what Aetna puts in the contract. So for us to try and manipulate a workforce, I think it's a little out of line when really the market's going to take what they need from, they're going to offer jobs for what they need. And we should be offering education for a skilled workforce to take those jobs. My other concern is that we are looking at cost, yes. So this degree, yes, is being offered, and it does cost more, but we don't seem to go to the schools and say, oh, let's take your coursework on English, and you don't need as many PhDs in English because, it's expensive too. I really think that we're trying to micromanage a profession that the marketplace will micromanage itself. We don't need to do it. If the jobs are there, we need to offer a skilled workforce and let the marketplace determine whether or not, if there are not enough jobs, then programs will scale themselves back because students won't be wanting those degrees. So I guess I'm just questioning our purpose of let's start looking at, do we look at now PhDs in, women's studies or things like that? Are there jobs out there for all of those people? So my concern is that we are maybe stepping a little outside of our scope as far as the coordinating board, that we're trying to solve all the problems of the nursing profession with a task force that really, like I said, medicine is not anything like it was when you started, David. It certainly is not what it was when I started 37 years ago. The future is going to determine a lot of different outcomes than what we're talking about here. And I think we're trying to keep things status quo. That's not the future of healthcare. We're not even going to be close to solving the problems of healthcare, especially for Texas, if we decide to close the doors on education. And my feeling is we should swing all the doors open, take everybody who'll come through the door, educate everybody as highly as we can. I do not know one patient who would say to you, I really want the nurse that has the least education. They're going to always say, give me the one who has the most education. I don't know that you can take the biggest workforce in healthcare and continue to say, you're the least educated at the table. Because that's really what we've done with nursing. They have the most people in the game, and it's the least educated profession. We should be talking right now about how we can educate more nurses as highly as we can and streamline them to the top. That's the way we change healthcare. And just my opinion, this draft really does point out some great things, I understand, but healthcare is not demanding tomorrow what we demand today. And if we're not prepared, if we're not preparing tomorrow's workforce for healthcare, again, Texas will be at the bottom of the bucket. That's not where the governor has asked us to be. The governor has asked us to be a destination healthcare center. He wants everyone around the world to come to Texas for health care. We just need to be preparing the skilled workforce to take care of that population. So I will agree with you on your recommendation for this and we'll hear about it then in January.
And Janelle, I'm not sure what exactly you're saying, what the point is that you're trying to make, because I don't see anything that we're doing or recommending here that's asking anyone to not continue to educate high-quality nurses at that standard. And in fact, all of the speakers said we need more, not less.
But the paper says there's not any benefits. The paper says there's not. It's too costly.
If you look at objective criteria, I agree with that. And we heard speaker after speaker say we don't have any science that proves the additional benefit. We believe that there's a benefit, and I think it's hard to say there wouldn't be some benefit by additional training. But as Dr. Scholl said, this is not a clinical degree. It's a degree in search of an application. And the science is not there. We have limited resources in this state for us to use funding to get the appropriate workforce. And when the nursing profession cannot tell me this is how many ADNs we need, how many BSNs we need, how many, et cetera, no, they have an 80-20, but the whole point is what about the higher level? And where we're failing, absolutely failing, is getting people interested in PhD and master's level nursing educators. And that is a question I always ask.
Who's going to be the leaders for all the associate degree and the BSN degrees? Who will be the leaders?
We heard from a couple of last...
The 0.5%? You're satisfied with that?
No, I'm not satisfied with that at all. And that's why every nursing dean that comes before that, I ask that same question. What can we do to cover this deficiency? You don't have enough nursing educators.
All right. Thank you.
So if we agree on that. Now, I also want to point out what Dr. Scholl pointed out, and one of the major issues I have with this whole thing, you have a national trade association, which is also a certifying association in nursing. They have made a unilateral decision that's going to have a negative impact on our ability to train our workforce for nurse anesthetists. They're going to make us have to spend more money to be able to train those nurses. They're going to make those nurses have to take more student debt to be able to train at that higher level. And no one can conclusively prove that those people are deficient and unable to provide nurse anesthesia.
I don't think we have any authority there.
Oh,
All we can
what
do,
I'm saying, we do
our
have authority.
role is to offer an education, a skilled education, for the jobs that are there.
Okay, and their goal is to make us spend more money to do it.
Like I said, we don't have any control over that unless you want to go to Washington or wherever it is.
We do, and I'll have a recommendation on that tomorrow.
Okay.
We do, and I'll be happy to explain to you what that alternative is.
Okay.
Because I understand that that alternative does not exist, but I'm willing to work to develop that alternative.
Okay.
All right.
We'll be all ears to that.
Thank you. Yes, and we'll look forward to that, David. Thank you. All right. We're going to continue to move on, and we're going now to the consideration of the white paper. We're going to have the staff report overview on the update of medical education, a survey of Texas medical schools, clinical clerkships, and rotations. Our discussion will include a summary of the survey responses, a review of the core clerkships and rotations, and presentation of survey responses. Discussion may also include expansion of clinical sites, including expansion of existing residency programs that offer first-year entering positions. Stacy, Dr. Stacy Silverman will be the one who will lead us in this conversation.
Thank you, Chairman Jenkins. Can you all hear me? All right. In April, the coordinating board directed staff to conduct a survey of the Texas medical schools undergraduate medical education with a focus on the availability of required clerkships and selective and elective rotations, and to look at the capacity of existing clinical education sites. So we knew that the medical schools had increased their class sizes by 31%. As this chart shows, the 2011-2012 medical school enrollment had an entering class size of 1,762 medical students. This actually fulfills the call from the Association of American Medical Colleges to increase medical school enrollments nationally by 30%. So Texas responded and actually overproduced and increased our enrollment 31% from fall 2002 to fall 2011. So in order to understand whether there was available capacity and to see if there was available space for the recent expansion, staff needed to understand the existing landscape of clinical education. We realized that the data detailing the requirements and location of third and fourth years of medical education had not been previously collected by the coordinating board and were not available elsewhere. So in order to help us document the existing clinical capacity, the staff convened a work group which included representatives from the Texas medical schools, Texas health-related institutions, and professional medicine, system office officials. We gathered them together and invited them to take a look at our survey instrument, give us feedback, and agree on the survey questions and on the definitions related to clinical education. So our report presents the results of that survey and the analysis of the data and survey responses that we received and the findings, and that's it. So next, this chart, while it's a little crowded on the slide, actually shows that Texas medical students must complete clerkships in 6 areas. This is also commonly referred to as the six-pack. So this is prior to graduation and prior to going on to their elective rotations. If you'll notice, the required clerkships are set by the medical schools, but they vary by school in length. They also vary by school in the number of sites available to each of their students. Some schools have additional core requirements, as you can see. For example, 4 of the medical schools require students to complete a clerkship in neurology, and UNT Health Science Center, Texas College of Osteopathic Medicine requires students to complete a manipulative medicine experience as well. The number of students at clerkship sites is fluid. This was somewhat surprising and something that, as staff, I learned an awful lot about. And it's determined, this fluidity is determined by several factors. The number of students that need the clerkship, the available faculty that are around to be able to supervise those students, the patient care experiences necessary for the student to adequately complete the objectives that they need to complete, all sorts of experiences they need to have, and whether other health professions are able to train at that site. Because the clerkships run in weeks, not a set schedule, not semesters, it is a very fluid rotation that takes place. So the medical schools vary substantially in the number of clinical sites available for the core clerkships, and the capacity of each of these sites also varies. So some clerkship sites may take care of or be able to accommodate 4 or 5 medical students, while another one can have more than 100 students. So also of note is that an awful lot of students go visiting other places. This was somewhat new. We knew that there was kind of a transfer in the elective years of students from one location to another. But what is commonly called the away rotation may range from 4 weeks out of state or out of country, or it may go up to 20 weeks and could include just visiting another medical school in Texas or a residency program in Texas, or some combination of those. So you can see that the number of visiting medical students coming into Texas is also taking place. This includes those students who are coming to a specific medical school. They may be in-state, going to another school, or they may be students coming from another country or another state. So you'll see that that number has increased in the last 3 years from 824 to 1,053. That means students coming from someplace else to do some portion of their clinical experience in Texas. We call those visiting medical students. So, Texas medical students, here's what we found. They're required to complete specific clinical education experiences. These vary. They vary by school, they vary in length, they vary in the number of clinical sites that are available, and they vary by the number of medical students assigned to those sites. What we also found is that the schools have developed strong and long-lasting relationships with the teaching hospitals, and they provide the majority of clinical sites used by the medical schools for their teaching clerkships and rotations. Also, the relationships that the medical schools have with the teaching hospitals are fluid. The clinical experiences available change based on student demand and needs, faculty availability, other health professions' use of the site, and patient load. So they change. We also found that schools, we also found that the schools and teaching hospitals negotiate agreements that include but that are not limited to the number of medical students that will complete a clinical experience at each teaching hospital. So the teaching hospitals and clinical sites, including physicians' offices, may allow medical students from more than one school to rotate through their clinics and their services. From 2009 to 2011, the average number of students placed into core clerkships increased at 3 medical schools to accommodate the state's increased medical student enrollment. 4 schools were responsible for 80% of the increase in the Texas medical school enrollments. And based on the 8 medical school responses, an estimated 42% of medical students from those 8 schools leave the state to complete clinical elective experiences someplace else. They allow medical students to explore their potential specialty choices and to better understand the available residency opportunities. From 2009 to 2011, the number of students, again, visiting, like we saw in the previous slide, increased by 28%. 2010 had the highest number of visiting students with 1,099. And again, these students spend 4 weeks or up to 20 weeks of clinical experiences in Texas. Interestingly, medical schools don't publish or report financial information related to the cost of educating a medical student at a clinical site. We asked the medical schools in our survey to provide us with information related to the costs of training a student at a clinical site and whether or not they paid those clinical sites to support the educational component of training those students. 3 of the medical schools reported paying a clinical site to allow their medical students to obtain required and elective clinical experiences. And those amounts ranged from $300,000 to $12.2 million. 2 medical schools reported that payment for their students was included in an institutional payment to their teaching partner but did not provide specific amounts. And 4 schools reported that they did not pay their clinical partners. So due to the limited number of medical schools that reported payment information and the wide range of the amounts reported, we were unable to draw any real conclusions related to the payments made by the medical schools to the clerkships. And that concludes my report, and we can go ahead and take up a discussion, and I'm happy to address any questions.
Before we go into that, we were going to let the commissioner make a comment.
Yes, thank you. Based on conversations among staff and based on some recommendations we've received from stakeholders, I am proposing that we change the recommendations, that we revise the section of recommendations. I ask you to turn to the recommendations. They're either at the end of the report or in the executive summary. I propose that we remove the recommendations regarding residencies. The residencies are actually based on, once again, internal discussions and comments we've received from stakeholders. They're really outside the scope of this report. So we are going to remove the first recommendation, the third recommendation, and the fourth recommendation in the current draft of the report. What we will do is we will combine those three recommendations into the text itself and simply offer these as closing comments in the report and refer the reader to further comments on these issues in the study that we recently did on graduate medical education. In addition, we're going to revise what is now the first recommendation. And we haven't finished the language. We haven't completed the language for the revised report, but it will say something like this. In addition to addressing some of the issues that were raised in this report regarding undergraduate medical education, it's important to note that the establishment or the expansion of new or current medical schools in itself will be insufficient to meet the need for medical care in Texas, and that we also will have to expand the number of residencies that are available to medical school graduates either from within Texas or outside of Texas. We will not say, we are proposing to this task force that in the final report we do not say that additional medical schools should not be established or opened until the residency positions exceed a certain proportion. We'll simply say that solving the issue or addressing the issue of the shortage of physicians in certain areas cannot be addressed solely by expanding or developing new medical schools. We also have to address the issue of the shortage of residencies.
Great. Moving along, we will now have our invited folks come up, input from medical school stakeholders. I invite, first of all, the deans of the Texas medical schools who are present, if you'll please come forward. Once again, I'll ask that we try to keep our comments into the 3-minute range if at all possible. Additionally, if there are other speakers who are not on the list as falling under the others category again, I invite you once again to fill out one of the speaker request forms, and we'll make sure that we get to you also under the other category. All right, having no idea of order how this should go, I'm going to start on my left, and we will move across, and then when the first row is finished, the second row is invited, and we'll work our way through everybody. So first of all, thank you for being here. We appreciate your attendance, and we look forward to your input. So if you'll please introduce yourself, and then we'll work our way through.
Thank you, Mr. Chairman. I'm Don Pesca. I'm the Dean of the Texas College of Osteopathic Medicine at the University of North Texas Health Science Center. And I guess based on the corrections, I ought to just say thank you. Are there any questions?
We were hoping that my comments might elicit that kind of response.
We thought it wise to have the commissioner give his comments before y'all spoke as opposed to after.
Wonderful suggestion. First, really, I want to acknowledge Dr. Silverman's team and the work they did to put this report together. And indeed, what is left in the recommendations is very important in that we do have a mechanism of capturing this data accurately going forward so we can inform these discussions. I only want to bring attention to two areas in the report for clarification and at least on perspective. One is the comment that relationships with teaching hospitals are fluid. I think that's a very important issue. We are currently working at or above our capacity for our core institutions. We have very limited ability to provide accommodations when unexpected events that require students to change rotations, faculty issues develop, or facilities are challenged. We operate dynamic and highly integrated systems that share resources with undergraduate and graduate education programs and provide continuing education in the learning sciences to our faculty, that which we call faculty development. And it's essential that the interrelationship is appreciated. I would also like to call attention to a specific aspect of the report where decreases in the average number of students completing clerkships at several sites is noted. And to characterize this as really reflecting our ability or our intent to decompress the overcrowding at those sites that we're currently experiencing. This should not be interpreted as vacancies that are now available. It takes us up to 2 years on average to build a new teaching site. For TCOM specifically, we continue to work with our existing affiliates and identify others that will enable us to establish comfortable margins for clerkship availability. Those are in keeping with our accreditation requirements. We earnestly seek to grow new GME and undergraduate programs in Fort Worth, but have found it necessary to engage sites well beyond North Texas in order to provide quality programming and enlist experienced faculty. At each site, we establish an administrative infrastructure, supply information technology, library services, research support, medical simulation, and faculty training to assure that students at all of our sites receive equivalent training. Our academic leadership maintains a frequent presence at each site to provide student services and career advising and confer with on-site faculty on the conduct of clerkships. We bring our faculty and administrative teams back to our parent campus on an annual basis to keep them well informed on curricular change. And in short, we see each teaching site as an extension of our own campus and a member of the UNT system. The members of the task force can likely know that we relocated the Faculty Development Center from Waco to our campus in order to maintain this level of oversight, and we do it at our own expense. To summarize, because I see the yellow card already, clearly with our current commitments to expand the healthcare workforce in Texas, we are utilizing all existing training opportunities, and we require the resources to establish more. Thank you.
Thank you. Any questions? Next, please.
Steve Greenberg. Steve Greenberg, Dean of Medical Education at Baylor College of Medicine. Thanks for the opportunity. There's very little I can add after Dr. Parada's comments. I think we were all in agreement with those. Just 2 comments I would make about Baylor. Just to underscore, at the undergraduate level, we are at capacity for training in the core clerkships. It's a daily issue. It's a complex, fluid, I'd call it flexible schedule that meet the demands of our education and our students. The other is the GME side of it, which is if you look at our affiliated hospitals where we train most of our residents, we're 20% to 50% above their caps right now in terms of what they're getting dollars for. So even if you go up by residency slots by 10%, you're still going to be using over-the-cap money unless there's another source for paying for those. So those 2 issues are put together. The other point I'd make for Baylor is that in our incoming residency class, we take a great deal of pride in bringing in people from all over the country, but also from the state of Texas, so that in the incoming residency classes for all our residents at Baylor, about 25% come from other Texas medical students, so other Texas medical schools. So between the Baylor and the other Texas schools, over half our residents are coming from the state of Texas right now. But thank you for your input. Thanks for the report, and we'll work with you, obviously, for keeping this data flowing so that you have an update as it's needed.
Great. Thank you. Questions? Next, please.
I'm Jose Manuel de la Rosa. I'm the founding dean of the Paul Foster School of Medicine in El Paso. As the other deans have stated, thank you, Commissioner Paredes, for bringing clarity to the recommendations and for integrating the concept of growing the need for residency sites along with growing the need for clerkship sites. Let me thank Dr. Silverman for the term fluidity in her report. I think that captures the concept of how actively moving each one of our multiple sites for clerkships are. These are negotiated existences with teaching hospitals. As an example, we bring to you our experience with William Beaumont Army Medical Center located in El Paso, Texas. This was formerly a major teaching site with the concept of fighting two wars. We have been forced to decommission that site as a clerkship site because we are unwilling to yield to the quality of physicians educating other physicians within that site without the appropriate numbers of educated, trained, and faculty educated, trained faculty developed within our system. I use that example to highlight the challenge of meeting the needs of the clerkships and meeting the needs of the residency program. Last but not least, I would like to plead our case as a developing medical school. We're not a new medical school. We're not an old medical school. We're sometimes caught between the vagrancies of existing recommendations and new recommendations. It is our plan to admit a class of 100 as we develop our programs in residency programs and fellowship programs. We may be inadvertently caught between the anticipated plans and the recommendations of the board. So thank you, Commissioner Paredes, for bringing clarity to the recommendations, and we look forward for your recommendations on the growth of residency programs.
Thank you.
Thank you. Next.
Good afternoon. I'm Sam Shoemaker. I'm the Dean at Texas A&M College of Medicine. Thank you for the opportunity to be here this afternoon. The issue of clerkship capacity is a very important one for the Texas A&M College of Medicine. We are a community-based medical school. We don't own a teaching hospital. We are a very highly distributed College of Medicine. We probably have less than 20 full-time physician employed faculty. The other 2,000 faculty that teach our medical students are community practicing doctors, and they are spread all over the state, literally. It is a full-time job for our faculty and staff to develop the relationships that we need with these practicing doctors and these hospitals across the state so that we have an adequate environment to educate our students. So the issue of clerkship capacity is near and dear to our heart and something we deal with every single day.
Right.
Thanks for the opportunity to make. Oh, and the other thing I guess I would say is we spend literally a quarter of our budget on paying the expenses related to the clinical training sites that we utilize. So we were the ones on the high end of the spectrum that provided the financial information.
Great.
Thank you.
Thank you. Appreciate that. And if any questions from the group that we have right here?
So in Dr. Silverman's presentation, she talked about a number of visiting medical students. Don't you have to have a reciprocal agreement? Isn't that covered under LCME accreditation? Can you kind of walk us through that? It would seem to the uninitiated the student can just go anywhere they want. They really have to go somewhere that's accredited.
That's true. For our medical students going somewhere else, they have to go to an approved program from our point of view. In the United States, if they're LCME accredited, that we use that as the accreditation. If they're going overseas, we have to have an affiliation agreement with that particular university or medical school and understand what they're going for and what they're going to do. The same is true coming into Baylor, and our affiliated hospitals, which is for electives, we take priority for U.S. students coming from other accredited schools before we would have them come in from outside other countries. But if they do come in, they also have to have an affiliation agreement with our institution.
And if I might ask for clarity, those visiting students that were cited in the report, I believe were mostly electives?
Yes.
Yeah, those were not core students. Those were fourth-year electives. And those frequently arranged through a national service called VSAS that works with the hospitals, and these are audition rotations for graduate medical education.
Yeah, I'd underscore that no students come in from any U.S. schools or foreign schools for the course.
Okay.
Which is traditionally the third year.
For most places, yes. It's what was shown somewhere between 40 and 52 weeks of the curriculum.
What Dr. Silverman aptly quoted as the six-pack.
Yeah. Right. So how do your schools all have a physician assistant program?
We do. I don't know about everyone.
That's not correct. We do not.
We do.
You not?
We do.
Okay. How many PAs are you graduating per year?
At UNT, we're at, I think we're at 72, 74, something like that. Some? Oh, I'm sorry.
And I'm sorry, I'm not sure exactly. We've just gone up, so it's a fluid number. It's over 40 a year, I think, at Baylor.
40 at Baylor, 60 at Southwestern.
They've just changed it to a master's program, and that's part of the issue is who's going into the master's program.
Okay. And are there any other deans that?
And then I believe it's around 24 a year in San Antonio.
24 in San Antonio?
I don't know the number at UTMB, but I know it's increasing.
Okay.
We have at Midland about 25 to 30.
Okay. So the question on and this really isn't UME, but it's workforce. The PAs are a tremendous force multiplier in the healthcare team, and there's a lot of modeling going on indicating that with a shrinking percentage per capita of the physician workforce, that the PA may be the example. Are your institutions in a position to expand that if they're appropriately funded? Would you have clinical material there and appropriate faculty?
At UNT, I don't want to say they're competing because we work with the PA school to coordinate their clinical rotations, which in many instances are identical to the medical student. We do have capacity overall to expand to approximately 80 students as a target, but we need to recruit additional faculty, PA faculty, to meet the accreditation requirement to get there. So that would be our target. There's about another 10 students from where we are now.
And is the PA program within the School of Medicine, or is it a separate school?
It's in our School of Health Professions, but they share both the basic science and clinical faculty with the School of Medicine.
So there's a School of Allied Health where the PA program sits separate under the umbrella of Baylor College of Medicine, but separate from the School of Medicine. So it has its own dean, and not only do they have PA program, but nurse anesthetist and another new program. And we're planning to grow the PA program, so the numbers are going up. Exactly where it ends, I don't remember the exact number, but there's a plan, strategic plan to increase the numbers.
All right, if you guys wouldn't mind, we'll bring or did you have something else? I'm sorry.
Well, that's right. I have one question. I'm sorry. If for this task force moving forward, what is your request? What is your action step that you want us to take?
If I was going to say very briefly, give us the opportunity to complete the growth that we've already been charged to do by the legislature and by our communities in which we provide service. We are still growing. We are still consuming resources to get to our target levels, and that will include, obviously, GME as part of that growth plan.
And if you have the resources, you feel like you can coordinate your spots, your clerkships, your spots for your undergraduates to go?
Yes.
As you expand?
Yes, given the resources, we can continue the growth. Without the resources, we're going to grow because we've already promised to do so. We're meeting our obligation. It's just that much harder.
I do think it is important to recognize the wording of fluidity. It's not a static number of positions. It's not a static number of locations. This will be a fluid process. It does take, as Dean Peschke has noted, about 2 to 3 years to develop a new core clerkship site. You have to develop faculty, you have to enter into agreements, you have to enter into an existing negotiation with the teaching hospital. From one year to the next, the core teaching sites may change. It takes a level of expertise to do that, and it takes some planning and some time to do that. And that would be something that we would ask. And then last but not least, I think you've already taken the major action of disarticulating the clerkships and the residency recommendations.
I'd echo the comments of Manny and Don, and I would just add that in our particular case, our first class of 200 students is going to hit third year next year. And in order to accommodate the expansion of our class size, we went to the extreme of opening an entirely new campus in Dallas, and that's working out just great. But it was obviously a long-term planning project and a huge amount of work in faculty development and logistics to bring an entirely new campus online to accommodate that growth in class size.
Thank you.
Thank you. If we could have the next group come up to the microphones, please. Once again, we'll start on my left on this side, please.
Good afternoon. I'm Dr. Varma from Texas Tech Health Sciences Center, Lubbock, which we have 3 campuses, Lubbock, Amarillo, and Permian Basin. And first I want to clarify regarding the fluid state of clerkship rotations. Each school, the curriculum, can you hear me? Oh, sorry. Sorry.
Thank you. We weren't sure.
Okay,
Thanks.
I'm sorry. Each school, the curriculum is developed by the faculty very carefully, and like ours, we had 8 weeks each for all 6 clerkship rotations, and this has been reviewed by LCME, and all schools in Texas and nation are accredited, and I think they reviewed that. So it is not necessarily that it is a fixed amount of number of weeks for each of them. And we had good results because with these 8 weeks each, I think that we, OBGYN and pediatrics, we have greater interest in the medical students, and the scores of USMLE in internal medicine has not gone down, rather gone up, because they had been cut from 12 weeks to 8 weeks. Second, we do not provide any payment to the sites. We do provide to the part-time faculty, and we do educate our community physicians before our students go for their clerkship rotation. Regarding commissioners, regarding GME funding, I do not know how we can separate it, but I think that we are hurting for the number of GME funding each school. Only thing I would suggest that if we increase it, there should be some proviso that if we increase the number of resident funding, first we should take our students and not go outside. It means the Texas students.
Thank you. Next, please.
My name is Patricia Butler. I'm the Senior Associate Dean for Educational Programs at University of Texas at Houston. Thank you for giving us the opportunity to be here. I want to thank Dr. Silverman for her diligent work. I have very little to add to the discussion. Just like everyone else, I think our major issue has always been capacity, and that does not only include the number of patients, but it's also the number of faculty teaching and supervising the students. Just on an anecdotal note, when we increased our medical student class in 2006-2007 from 200 to 220 and then 230, we ended up having a site visit from the Secretariat of the LCME, who were not initially convinced that we had the patients nor the faculty or other resources actually to educate our students. So we've been very careful to really keep our resources there for the education of our students. And we do meet with our clerkship directors who direct all our clerkships on a monthly basis, and we hear every month how they're struggling to assign the students to various locations. Another piece of information, we have over 230 students graduating this year, and we will be offering 178 first-year positions through the match. So we really need more GME positions, just like everyone else has said. Thank you.
Thank you.
Hi. Excuse me. I'm Judy Rowan. I'm the Associate Dean for Educational Affairs at UTMB in Galveston. And fluid implies that there is no barrier to flow. So I'm not entirely sure it's the right word. I see it as an enormous jigsaw puzzle that I have to put together constantly and frequently have to reassemble as pieces disappear. I relayed the story in my answer that we had a site that we had been happily using that's very close to our university for our psychiatry clerkship, that the day the students arrived, they were turned away. So that was a shock. It caused some scrambling, and we recovered from that shock, but we just can't afford to lose more capacity that we might have so that we can plug in when we have things happen, hurricanes, things like that. It is a constant issue. I even have to rent apartments for our students so that I can shift them around from place to place. We also do compete with our own physician assistant students, but we actually have a lovely relationship with them, so we talk to them, so that works out okay. They are in a different school also. We have come into places where we are competing with other medical schools. When sites are being paid, sometimes they feel that they can no longer take two schools. They can only take students from one school. So that does get to be where there's kind of the Wild West frontier. But I'm glad you took out the stuff about residencies. That takes away a lot of the explaining I have to do back home.
Great, thank you.
Good afternoon. I'm David Jones. I'm the Senior Associate Dean for Admissions at the School of Medicine in San Antonio. First, I want to thank you for addressing issues that will continue to ensure the excellence of the educational program for our students. That's very obviously the most important thing to us. Fluidity is important. Flexibility is important. I can recall one afternoon walking in to give a lecture to students in anesthesiology, and there were 5 UTMB students sitting there from the hurricane. And although we were at capacity, this was a reason to accommodate those students. So I endorse what's been said previously, but I really think it's important, as we all deal with capacity, that we deal with flexibility issues as well. Thank you.
Thank you. Any questions? Dave?
So the question is, and there was at least a statement that you would be competing on price to be able to retain that. Is that a common thing where someone else is willing to pay, and do we risk a bidding war, or is there truly enough capacity out there for us to continue to expand?
I think there's the potential for a bidding war. I don't think we're there yet, but we use a lot of community sites because we think it's important to have students see how medicine is practiced in primary care. So we use community sites for family medicine, internal medicine, and pediatrics predominantly, and a little bit in other sites as well. In fact, we have a required 4th-year experience where they're in the community. And we have had practices say that they can no longer work with our students because they are now working for another medical school that has paid them to do that. Because we do not have the resources, or at least the way we've distributed the resources, we don't have the resources to be paying the community practitioners we work with.
Y'all experience any of that?
Well, I might mention there's a good lesson to be learned in some of the New York hospitals where this exact event came up, where there was competition. Ultimately, all of the sites were closed at one hospital to one of the public medical schools because the hospital was being paid to take over clerkship spots for 3rd-year students from another medical school.
Actually, we do not directly pay our clinical affiliates for medical student education. There are obviously indirect costs associated with paying for faculty who are teaching and supervising, but nothing directly to the hospitals.
We are not paying any sites, but we do pay some of the community physicians for their time, and they are our part-time clinical faculty. And I think clinical sites have not asked for any money, so hopefully they don't.
And so what do you need from us as we move ahead and ask you to move ahead?
I would say that we need more physicians as we all know. And I think that with the new schools, plus also allow some of the existing schools, if they have the capacity to increase the number of enrollment, and if they have the clinical sites, patients, and I think they can do that, then you should allow us to do that.
So you think as you expand, you would have spots too?
Yes, ma'am.
You have spots?
Yes, we have looked, at least we can do 30 more.
Okay.
Now, is that 30 more students or 30 more places to send them?
No, students.
Right.
30 students, we can take more.
I think I was going to say the challenge is that as different physician extender programs increase in their capacity, then it continues to increase the pressure on the clinical training sites.
Right.
So even though we don't increase in the number of medical students, those programs are increasing. So that increases the pressure then on the experiences of our own students and the opportunity with the jigsaw puzzle to go from 1,000 pieces to 2,000 pieces and then try and make it fit in the same spot.
Well, and as you have students and you normally use the same facilities, there are nursing students, respiratory therapy students. I mean, there's students
That's correct.
everywhere, and you can only absorb so many bodies in
That's
those
correct.
hallways.
That's right.
That's right.
And do you
And residents.
and residents, yes, of course. Do you feel like you might have some new opportunities with other communities? For instance, A&M says they've spread out all over the state. Is that something you've been?
We're all over the state also, pretty much, for our community placements. In fact, I even run our rural health program. But there's still a lot of training that happens in hospitals.
Oh, yes.
And there needs to be, you've heard what it takes to develop the faculty and develop the site. So we tend to end up being in larger facilities. And so that kind of does restrict our movement a little bit.
And I think the real challenge is there's another side to this, and that is the willingness on the part of the hospitals and the community physician groups to bring in students, because one of the things that's very important as individual income goes down on the part of physicians, they need to see more patients, and trainees slow them down, without a doubt. And I think that's part of the issue as well as we address the ability of the clinical care sites to support our students.
I was explaining that to Fred earlier, that hospitals are very cognizant of the risk, the high intense supervision you have to give to students. I will tell you out of personal experience, very personal experience, your length of stay normally is affected by bringing in students. Your duplication of testing, things like that happen. They just happen. And so it is a very high risk for a hospital who has a very tight net revenue to decide to bring in students. And that's why the question about payment is probably going to be an issue for some of your newer sites if you try to expand to maybe a medium-sized community hospital, something like that. Is that some of the pushback you're feeling? Or?
Yeah. I have one suggestion that Dr. Silverman has very, I think, nicely done the report regarding our students taking elective outside or so. I think we should start monitoring our global health electives. Many students are going outside United States, going to Africa, Asia, elsewhere. I think we should monitor that also and what kind of impact it has.
The LCME has a new standard addressing global health issues and have actually kind of tightened it up. The global health program we have at UTMB is a major draw for our students, and they tend to be people very committed to service, and they see that as a portion of what they do in the future, so I would really hate to see that limited.
I would agree.
David.
Who funds that?
There are a variety of foundations, and the students apply for grants to pay for their travel. We don't pay for their travel.
Not the state, it's not the student?
No, mostly
sometimes it's the
students.
student.
Mostly students.
The students will often pay for it themselves, but we the people in our global health program point them towards resources where they can apply for grants and funding.
There's a lady in the back that's got her hand up.
Primary care.
Primary care makes sense.
So the overall, we've increased our student enrollment by 31% in the last decade. Say we're tasked to do that again. Do you have the physical capacity to take on new first and second year students in your physical facility at this time? I'm not assuming additional faculty, just a physical facility.
Yes.
First and second year, it doesn't matter because students don't go to class anymore.
They didn't in 1980 either.
We're very fortunate to have a new building coming online. So the answer to that is yes. But the other part of that is it's unconscionable to take those students in when you don't have the clinical training sites.
Right.
Well, and I guess what I'm getting at, there's talk of new medical schools, but there is an alternative option of expanding the current first two-year experience and then having other satellite locations to do your clinical training. A lot of other states have used that model where all of the students train for the first and second year at one location, and there are 4 or 5 other areas where they go for the additional 2 years of clinical training.
We have that in place now with our Regional Academic Health Center down in the Lower Rio Grande Valley, and we train up to 24 students there in their 3rd and 4th year.
And if there was additional opportunity there to train more students down there, could you take that excess capacity with your physical plant the way it is?
So that's the direction that's currently planned.
Okay.
We could not. Our lecture halls, we do have required educational activities for our first and second year students where all the students have to be there, and the lecture hall is at capacity. There's not one seat, so we really are there.
So you really need another lecture hall to expand?
We would.
Yeah.
We don't have we are okay. We will be doing all right. I think good model what you were saying about that first 2 years in last millennium, Dartmouth did only first 2 years, and in the 3rd year and 4th year they branched out to Harvard and other schools.
We have lecture hall space. We just opened a new testing facility that'll seat 300 students. But we do a lot of small group teaching, and our small group rooms, we have about 28 to 32, depending how you count. And if we did things in shifts, it could work. But one of the rate limiting steps is actually your gross anatomy lab. But again, if you did it in shifts, so if you held the class more than once, you could take more first and second year students. Not in the same linear model we have now, but it could be done. But we could not take more clinical year students right now. And as you may or may not know, we train 48 per year in Austin. So we sort of already have that model, where we have some go elsewhere for 3rd and 4th year.
And when do they come to Austin?
Third year, and then 4th year, nobody stays any place. So I would say they're in Austin, but they're everywhere.
Thank you.
All right, do we have any other Texas medical school? Yes, the last
Our
one.
colleagues from Southwestern have
Yes.
been very polite.
They're very kind to be at the end. We'll invite them up now. They're going to have the entire dais to themselves.
Dean, don't you mean they're amazingly well behaved today?
Hi, my name is Angela Mahalik. I'm the Associate Dean for Student Affairs at UT Southwestern. I just wanted to thank you again. I don't have too much to offer. I think there was one piece of a discrepancy on the visiting students program. I think there was one year that UT Southwestern was missing the numbers, which may have skewed the data anyway. But I think the other thing to note is that because of the number of residency positions out there, there's a shortage. Residency matching to residency across the country has become more competitive because there are a lot more students applying for those positions, and I think the whole going away rotation thing has increased for that reason, because students have to become known to these residency programs to be able to match there. So I think the market, I mean, that's just another example of why we're of being short on residency programs in general.
I'm Sue Cox. I'm the UT Southwestern Regional Dean here in Austin, and I really don't have a lot to add. I think Stacy probably needs a psychiatrist for taking on that report that she put together. I mean, that was a monumental task when you look at all the data. And rather than using the word fluid, and I agree with Judy, that's kind of, they go everywhere, why not use the word dynamic? We're dynamic in what we do with our clerkships. When a student gets sick and has to rotate off, somebody else rotates in, and we move students around all the time to accommodate their unique schedules and their unique features. And I did notice I think if you take the Southwestern number for that part that Angela pointed out, you'll see there's not been that much of an increase in visiting students. That's pretty much the same. And again, I want to thank everybody for their work on the coordinating board, and we appreciate your support, and we are especially grateful that you removed the GME recommendations from the recommendations at the time that you did. Thank you.
Great. Any questions? Great. Thank you all. Appreciate it. Yep. Yeah. Sorry, David.
So I think you heard me ask the others. I know you have a third, fourth year campus here in, is it in Round Rock or is it actually in Austin?
UT Southwestern does not have a campus in Austin. We support the 15 residency programs here.
Okay.
The UTMB students of Judy's are here in Austin.
So that's more of that fluid thing, right? Yeah. So looking at the physical...
Dynamic.
Oh,
Dynamic.
Yeah,
We're going
right.
with dynamic.
Y'all are dynamic. Everybody else is fluid. It's getting late. The question I would have for you along the lines of the others, knowing your physical plant in Dallas, is there excess capacity to put more first and second year students into your physical plant?
Again, I wasn't really being facetious when I yelled from the back of the room that, we could take more because they don't come to class after the first year, but the rate limiting factor, the anatomy labs, and to do what Judy suggested, having half here and doing them in shifts increases the demand on our teachers. It will increase the demand on all the teaching faculty, and I think it would make us burst at the seams.
So the answer is yes, but it would require significant resources.
Yes, sir.
Okay. But those resources to double your size of your class would probably be less than building a brand new medical school.
Doubtful.
Double the faculty.
We'd have to double the faculty. You'd have to build the whole, literally take the new medical school that you're planning and move it to UT Southwestern or UT whatever, or Texas Tech or Texas A&M. Because you need the faculty, you need the infrastructure expansion.
Great. Thank you all. Appreciate it.
Thank you.
All right, we're going to now have the folks from the American University of the Caribbean to come forward, please.
Good afternoon and good evening.
Approaching.
First of all, I want to thank each and every one of you for the opportunity to present today. I'd like to address the board in regard to our pending application. I'm Bruce Kaplan, the Dean of the American University of the Caribbean School of Medicine. Our current Texas students desire to enter into clinical training here, begin primary care residencies, and serve in both the underserved and rural areas at no cost to the state of Texas, while helping to address your critical underserved manpower deficiency. For years, AUC graduates have chosen to fill resident slots in Texas teaching hospitals and have also become licensed physicians in the state. However, your opportunity, i.e. the hospitals, to evaluate and pick our best students is actually best afforded by observation in the core clerkships and elective clerkships. Texas residents who are AUC graduates want to return home. They want to serve their communities. they want to do training in the state, do not want to have to leave your state. AUC has met all the Texas Higher Education Coordinating Board requirements for a certificate of authority and has not only been collaborative, but has voluntarily offered additional restrictive covenants to gain approval. AUC has consistently demonstrated a commitment of academic quality and student success, as evidenced through our application. The United States Department of Education has determined that AUC's accreditation standards are comparable to those by the Liaison Committee of Medical Education, which accredits U.S. medical schools. As a fellow educator, I share similar concerns and mindfulness regarding all the capacity and clerkship issues brought up by your deans today. Your draft survey indicates there is a great variation, and I had the term fluidity, but I've changed it to dynamics, in determining actual clerkship need and capacity in Texas. The evaluation of capacity was based on current clerkship numbers as demonstrated by the Texas medical schools. We recognize that this is the first time information like this has been collected, and we appreciate the effort, and they understand the difficulty in getting the information. However, given our experience in other jurisdictions, we submit that all substantial stakeholders, including hospitals, hospital associations, community health centers, also should have input into the final draft product. We understand that the task force and other interested parties want to know and understand how to enable Texas residents to complete clerkships in the state and how, if they will work in the state. In this regard, I'd like to briefly cite some examples, specific examples, how AUC students who entered into clerkships, residencies, and then prominent positions in hospitals or staffmanship, and how we coexisted in institutions where both LCME and AOA students were at the same institution. I'm going to offer briefly 3 bios of where this has occurred. The first one is St. John's Providence Hospital in Southfield, Michigan. AUC has been an educational partner for over 30 years. Providence is a teaching hospital of Wayne State University School of Medicine and Michigan State University College of Osteopathic Medicine. All 3 schools have rotations, core rotations at this site. However, by far, the most primary care slots in the residency programs, including internal medicine and family medicine, have been filled by the AUC graduates and not the AOA or LCME graduates. Many of these have continued on to both staff and faculty positions. AUC does provide educational stipends to the hospital that support graduate medical education, student education, and the physical plan for all users to share without any restriction. This has helped provide a new medical education suite for the administration. It funds residents to attend national or international meetings for paper presentations, and it also funded a American College of Surgery Level 2 certified simulation lab for all users, all trainers at the hospital. Currently, we are working at the site to develop over-the-fund cap funding for residents to expand resident slots that are needed and looking for a different payment methodology. At Nassau University Medical Center, which is located on Long Island, also a key clinical campus partner with AUC, which houses Stony Brook, NICOM, and AUC students. Nassau University Medical Center is the only community hospital and safety net hospital for the entire area. It underserves both the underinsured and Medicaid patients within a large geographical area. It had little or no funding to support medical education, had an antiquated 50-year-old amphitheater, had no particular location for grand rounds and lectures. It had no funds to secure the latest internet capability for all its trainers. AUC provided this funding, and now the hospital has a contemporary and cutting-edge auditorium, updated library, and it's shared among all learning users. A new method in training and clerkship generation is a Miami Beach Community Health Center, which is an FQHC center in Florida, federally qualified health center. We established a new method of ambulatory-based training, and so as to not interfere with LCM students in current rotations, AUC funded additional faculty to oversee students on off-cycle periods. For example, on labor and delivery, while the majority of the LCME students were on daytime shifts, AUC students rotated on night shifts and weekends. Additional faculty was hired to supervise and make sure they had appropriate education. This particular model has proved effective in using unused capacity and to the betterment of all students and institutions involved. Due to the time, I just cut to the chase here. We respectfully understand the dynamics and capacity issue within the state of Texas. We have had our application pending probably for a year to a year and a half now. I've gone through multiple meetings and delay here. And once again, notwithstanding the greater issue that you have in the state, and I'm speaking to one specific issue on behalf of AUC, would like to see the opportunity to progress on this application and move forward with the pilot project as mentioned in prior meetings, and look forward to any direction and suggestions you have at the meeting today. Thank you.
Questions? Additional comments? Okay.
Thank you very much.
Thank you very much. We have one other under the list of others, David Wright, the Council of Medical Education, Texas Medical Association.
My apologies. I'm Marcia Collins, Director of Medical Education.
Well,
Dr. Wright had an electrical fire in his car this afternoon and was not able to.
That's not a good day.
No,
Is he okay?
it's not. Yes, he's fine. With your indulgence, may I share his comments
Please.
with you? Thank you. They're very brief.
Marcia, turn your microphone on, please.
Is it?
Thank you.
A little closer.
Dr. David Wright serves as chair of the Texas Medical Association's Council of Medical Education. I serve as staff to that council. First and foremost, Dr. Wright felt that it was reasonable to conclude from the undergraduate medical education report that there is not excess capacity for medical student clerkships in the state. And I'm also going to not read his comments in relation to the GME proposals. The report does show some variance in the length of the clerkships, and we would emphasize the need to preserve a medical school environment that allows for this flexibility. This is characteristic of medical education across the U.S. It's not unique to our state. All of our schools meet the accreditation requirements. All of our graduates must pass the same national exams. Dr. Wright felt it was meaningful to add an acknowledgement of this type to the report. TMA's position has not changed. We believe the state should focus on the needs of Texas medical students, those that are enrolled in our schools. They are the extent of our responsibility. We should ensure that medical students in our state are our priority. We should not have public policies that allow them to be displaced by students from other countries that can take their place. This is not in the best interest of our state. 20 additional students is not a significant number if there were 20 extra slots, but having no excess capacity means just that. It is important to note that there are 35 medical schools in the Caribbean that offer instruction in English, and the numbers are growing. Policies governing the accreditation of U.S. medical schools specify that core clinical training be provided by the parent medical school. Accordingly, TMA's policy strongly objects to the practice of substituting clerkships in the U.S. for the core clinical curriculum of foreign medical schools. The report indicates that meaningful assessments were not possible based on the economic data that was provided in the survey. Dr. Wright felt that the fact that a good portion of the schools reported that they do not pay for clerkships at this time was a significant finding. Should all the schools be forced to pay for clerkships, it can be expected that those costs will then be passed on to students, perhaps through tuition by necessity or monies taken from other areas of medical education, and no one wants to see an increase in medical education costs. The timing is not right to take on students from other medical schools. Thank you for the opportunity to provide Dr. Wright's comments to you today.
Thank you. Questions? Thank you very much.
Thank you.
Additionally, for the record, we have copies of written remarks that were provided to the task force from Dr. Ken Shine and Randolph Whittington, which are also available on the website. So their comments are there and can be looked at, along with the meeting agenda and materials of the task force, all on the website. Okay. Let me thank everybody for being here and your comments. We really appreciate the input and the participation in the process. So now to the task force. We can have consideration for what we've heard today.
Did we take action on the first report on the nursing? I believe I made a motion.
Yes, you did.
I don't know if we ever took an action on that to recommend forwarding that to the board.
I think we did.
I thought that we did, but if we haven't, we can make an affirmative that is the task force recommendation.
I don't believe there was ever a vote on the motion, but it was clearly apparent that there was consensus with you and Ms. Shepard both speaking in favor of that point. And so that's the reason I didn't stand up before. But if you want to take a motion, that's perfectly fine as well.
As a task force, let's go ahead and do so.
Why don't I make another motion since I didn't get a second on the first, and I'll move that we send both reports to the January board meeting.
You're moving both of the that we've heard today.
Yes, and ask that staff be permitted to make technical changes, add anything on that as we talked of earlier, but that it would be, since we're a task force of the board, that it go straight to the board meeting in January.
I'll second it.
That's second, and that would mean that we all say aye for that then. Aye. Okay. A little weird when you've got three people here. Sorry, Munir.
And on the issue of American University of the Caribbean, now that we have our answer from the Attorney General, I believe we should return that to the full board as well, and that there were some stakeholders who had, from the legislature, who had expressed some concern. I would ask that staff be empowered to reach out to those individuals before the next board meeting.
And the purpose would be to get their thoughts if there's going to be legislation filed. Is that what you're saying?
I don't know what they're anticipating as the next step. Our concern was, can we even do this? Apparently the Attorney General believes we can. And their concern was they thought they should be taking it up, and now they're about to go in session. So I think it would be the proper thing to ask them, what is your intention?
Right.
Before otherwise we should, proceed in addressing the request.
I'll second that.
Okay. Well, I guess we're all in favor of that also. All right. Yes. All right. Having had both of those matters taken care of in that manner, I think that we have come to the point of adjournment then. Is there,
Mr. Chairman, if I may,
Gregor, please.
I would like to thank my staff, Stacy Silverman and Elizabeth Mayer, for working on the undergraduate medical education report, Chris Fowler, Suzanne Pickens, and Lucy Heston, and Donna Carlin. Yeah, I couldn't forget Donna on nursing, for their work on the DNP study as well. So thank you very much.
Let me say this, in talking to Stacy, it was comforting to hear how that much you had learned in doing that report, because, oh my gosh, it's been nothing but a learning experience from my perspective. So I'm glad I'm not the only one who is learning in this process, and I'm sure we will all continue to do so. So once again, the idea of this task force, that this is a forum where we can have dialogue, we can have an exchange of thought processes and perspectives. And we truly, sincerely appreciate each of you taking the time to be here as we all work together on each of these difficult tasks. And with that, I think our task force will be adjourned. Thank you.